रंजना मॅडम, डॉक्टर रंजना मैडम,
यस सर, यस सर।
आपको मैंने होस्ट बना दिया।
जी सर।
तो हाँ ठीक है।
हाँ
तो
जी
आप,
सर।
हाँ, आप कंटिन्यू करें। और मैंने यूट्यूब पे भी ये किया है लाइव।
हाँ हाँ जी सर। जी सर। ओह,
करना है A very warm morning to one and all present here. Again, I welcome you all on second day of this national conference. Thank you to each and every one of you for being here with us today. I, Ms. Priyanka, take this opportunity to welcome all the eminent speaker, chairperson, and Mrs. Ashwini Khope, Associate Professor as an observer for today's conference, and all participants this conference. The competency are intended to help guide to education, preparation of nurse teacher, ensure educational quality and accountability, contribute to improving the quality of nursing care and outcome of health services. Now, I request to Ms. Savita Pohikar, Associate Professor, Medical Surgical Nursing Department, SRMM College of Nursing, to start our first session.
Hello and welcome. Welcome you all once again on behalf of SRMM College of Nursing in the second day of National Conference. So let's start our today's session with full enthusiasm, past, present and future of integration of nursing services and nursing education, which will be dealing by Dr. Vatsala, Dean, College of Nursing, Christian Medical College, Vellore. The chairperson for this session is Professor Jaya Gavai, Dean Academic, Department of Mental Health Nursing, Savangi Meghi Vardha. She is currently working as a Dean Academic in Faculty of Nursing, SRMM College of Nursing. She obtained her master degree from the Tamagi Institute of Medical Sciences, deemed to be University, Savangi Meghi Vardha. She is having 34 years of professional experience in a variety of clinical services in Ministry of Health, Oman for 11 years. She is having teaching experience, research, administration, and management settings also. She has published various articles and presented paper and poster in various conferences. She awarded as a Best Employee in the year of 1999 and Best Teacher in the year of 2020. I request Professor Jaya Gavai ma'am to introduce our speaker of the day to our esteemed participants.
Thank you, Savita. Good morning to all the respected speakers and all the participants. I'm introducing the speaker, Dr. Vatsala Sadar Madam. She is currently working as a professor and Dean at Christian Medical College of Nursing, Vellore. And she is having 30 years of undergraduate teaching experience and 25 years in postgraduate teaching. She has obtained her PhD degree from Christian Medical College, Vellore, South India. She has faculty HOD, Department of Community and Mental Health in Sultan Qaboos University, Muscat. Experience at Örebro University, Sweden as part of faculty exchange program in primary healthcare and training program at University of Nottingham, UK, and systematic review. She is PhD guide and the National PhD Consortium in collaboration with Indian Nursing Council, Rajiv Gandhi University of Health Sciences, Bangalore, July 2010 till date. And she is PhD guide under the Tamil Nadu Dr. MGR Medical University, Chennai, April 2013 till date. And she also is the member of TNI, Alumina, Association of College of Nursing, National Research Society of India, Society of Community Health Nurses in India, Society of Midwives Association of India, Oman Cancer Association, National Nurses League. She was also a member of accreditation committees She has presented 15 international papers and 49 national papers. She is UG and PG examiners and evaluator too. She has published books and chapters, scientific research publications 26. And she is having various academic responsibilities as well as administrative responsibilities also. May I introduce Dr. Varshala Madam for the present session. The theme of this session is past, present, and future of integration of nursing services with nursing education. I welcome you, Madam.
Thank you, Professor Jai Gauri. Good morning to all the resource persons as well as the participants. I'm so delighted to meet you all in the virtual platform, My Nursing Fraternity. And I thank Professor Jai Gauri and Dr. Anjana Sharma for giving me this opportunity. And I congratulate SRMM College of Nursing for organizing this on this topic, which is the need of the hour, integration of nursing education and competency-based clinical practices, the need of the hour. I was so excited to look at the theme because as it is rightly mentioned, it is the need of the hour. Though the topic is past, present and future, I will also share most of it will be our experience in the past and in the present and what we look forward for the future. Thank you once again for the opportunity given. Just give me a few minutes to share my slides. Okay, the outline of my presentation would go like this. I would briefly introduce the topic and then about nursing education and services and what is integration and historical background of integration model in CMC. And since we are the pioneer in this model, practicing this model since 1968, and also what are the benefits which we have gained and what are the challenges we face, and little bit about the public health program where we again practice the same model, and also what are the future guidelines and how to go about implementing this model. As it is said in the slide, the demand for big expansion of health workforce is going on in the country as well as across the globe. Adequate and effective human resources are very much essential, especially to take care of the people's health. And nurses are the important resource in the health workforce, and hence competent and adequate nursing workforce is highly relevant in today's healthcare system and delivery. And it is very important that we as nurses take this as a lead and we take part actively in the change of this healthcare delivery models. We need to make a change in the traditional healthcare delivery models. For that, education and practice go hand in hand. Everywhere you must have heard there is a gap between theory and practice. This is a common slogan everywhere. It is talked about now, from all the educational institute as well as in the service area. So the gap between theory and practice is realized or recognized by the nursing fraternity as well as by our medical colleagues. So we have to address this issue. So I feel that integration model will definitely address this issue. However, another important area is nowadays we give greater importance for the disease prevention and health promotion, and our nurses and nursing students need to be prepared adequately with essential core competencies which are required from their educational training. And also essentiality of improving the access and quality, considering the patient safety is very important. And we are now in the era of technology, a lot of advancement in the field of science as well as the new pandemic has come and it has made which has given a value for nurses across the globe, and everywhere the nurses are recognized. However, we find that there is a shortage of nurses in the country as well as across the globe. So this particular model which we were practicing or we are practicing will definitely pool the resources of both educators and the nursing service personnel, and I'm sure we will be able to provide a cost-effective education and the patient care by using this model. I will not go into the details. Some of the health innovations through nurses for the future generation. There are new pathways for the next generation of nurses, and so we need to move into the change from the traditional way of training our students, are traditional training models. And there are new nursing knowledge and skills, as I mentioned, because of the technology and advancement. We need to update ourselves, and the teachers need to update themselves. They need to bring the classroom to the clinical area and clinical area to the classroom. That is how we can achieve this knowledge, changes in the knowledge and the core competencies the nursing student or the nurses need. And nurses need to educate the policy makers on expanded roles. There are, because of this changes, there are a lot of expanded roles in the hospital as well as in the education side. So we need to educate our policy makers at the state level, at the central level about these expanded roles. And nursing education, we need to be efficient, safe, and we need to provide high quality healthcare to our patients. These are some of the things which we have to keep in mind. And as nursing fraternity looking into the future, these are the recommendations by the WHO. Nurse-led service models are expected, and focus on hospital care, refocus on prevention and health promotion. As I mentioned, high quality care and patient safety is expected of us, and integrated community-based people-oriented care. These are the themes kept by WHO. When we educate our students ultimately to provide care to the patients in the hospital. With this background, I'll go on to nursing profession is faced with increasingly complex healthcare issues driven by medical and technological advancement, increased number of people living with chronic diseases and aging problem. And again, you can add the pandemic now, with which we are now struggling with a lot of challenges. And at present, in most of the educational institutions and hospitals, this is a scenario. You find the nursing education, service, and research in three different, circles. So it is all different. Education is given in one school or college of nursing. The students go to practice in another hospital, and there is no connection. And research is carried out in some other institution. So nursing education and practice historically were separate. Even now, in most of the institutions, it is separate. In some of the institutions in the country, the educational institutions are trying to integrate this education and service. And the next important thing what we look at is now is there is a gap which exists between service and the education, because there is no connection between the educational teachers and the service. There is connection, but it is not that integrated way of giving the nursing education or giving the clinical experience for the students. There is a compartmentalization between the education and the service, and the nursing colleges are separately under separate administration, and they have very limited control over the nursing hospital environment when they take the students to the clinical area for practice. So this is how it was in the past, and even now it exists in most of the institutions in the country. And I would like to briefly introduce you about the integration model in CMC. As I told, it is a unique model. Though it was introduced in 1968, it took 8 years of struggle to get this done. So when we look back and read the history of College of Nursing integration model, actually it started with a lot of opposition from the service side staff as well as with the administration, and they conducted some pilot study, and after that only it was introduced in the year 1968. So how it was started? In 1960, we had 11 faculty with the MSc Nursing. That time we did not have a master's program in India, and most of them went and had from USA. And out of the 11 faculty, 8 of them had specialization in the clinical area: medical surgical nursing, obstetric nursing, psychiatric nursing. So they were clinical experts with the PG experience. So when they took, that time it was School of Nursing, when they took the students to the hospital, they faced lot of challenges. Whatever they learned about the clinical expertise or clinical competencies, they were not able to teach to the students in the bedside because there was a reservation in the hospital side. In the hospital, the senior staff, the nursing supervisors or the ward in charges or the ward sisters, no, they were with post-diploma qualification. However, they had a resistance that these educators come and teaching them. Things were not given to the teachers to practice. You know, the learning environment was stressful for the teachers as well as for the students. So the teachers that time, this MSc faculty sat and discussed, and they were thinking, can we, integrate both? Integrate both means make use of the educators in providing or helping with the clinical area to give patient care. At the same time, the supervisors, nursing supervisors or the ward sisters or the ward in charges, to get them involved in teaching our students. That is how they deliberated, and after long discussion with the administration, and they properly laid down how this model will work out and how it will be beneficial to the students, to the patient care, area, as well as for the nurses who are working in the clinical area, as well as the educators. Like that it was taught. The educators can make use of what they have learned, put it into practice in teaching. At the same time, the changes which happens in the clinical area, they can learn and take it to the classroom. Ultimately, you prepare a good graduate with excellent competencies to provide patient care. So that is how they thought about, and they thought that we will roll out that. And again, it was rolled out in 67 as a pilot study or a pilot program, and they found that it is feasible, and then they introduced. So we are practicing this for 50 years, and it is continuously we are practicing, and it is successful. And the faculty play a dual role, 2 roles. In the college, they have a faculty academic title, professor, associate professor, assistant professor. And when they go to clinical area, they are called as nurse managers. And each of the nurse managers have assigned clinical area. We know those days we had, very less number of inpatients. So we had for every ward 1 nurse manager. Now we have expanded so much. Now we have given 2 wards for 1 nurse manager, and they are involved in, training the ward in charges as well as the staff nurses in the competencies, as well as guiding them and supervising them. And also they are responsible for taking teachers in the classes in the clinic, in the school or college, and then again give the clinical experience for the students in the clinical area, which in which they are assigned or in which they are posted. So this is the dual role, and through this they were able to contribute to the education, patient care, as well as clinical research. Now it is mandatory that all the nursing faculty need to have research, especially the clinical research for their promotion, for their contract renewal. All that is coming up, and which is already implemented in some of the institutions for accreditation for other reasons. So this is mandatory, so they have to have research. So they have a very good clinical environment to do clinical research. So through clinical research, they produce the evidences which can be put into practice in the patient care area, and hence we can have best practices to be followed in the clinical area, ultimately leading to improving the quality of patient care. So in CMC, we practice both in the hospital and community settings, and we have done few evaluations, and the evaluations also bring about the strengths, at the same time what are the challenges we face. Quickly, few slides. We are 113 years old nursing education. So we have implemented this model for teaching all the different levels of courses in our institution. So we run all these different programs. We have currently 858 students in our institution. And to say about the nursing service area, we are the largest multi-speciality hospital. We have added 1,500 beds. So we have 4,500 beds, and we have around 4,200 staff nurses. And we are certified by NABH, our hospital, and we also have received nursing excellence certification by NABH, and mandatory. There are many things. One of it is BLS and ACLS in critical care areas, and all the staff nurses who enter our institution for appointment, first month they have a competency based training, and after the training the core competencies are assessed, and based on that the appointment is given. And then on the job regularly, there is on the job training for our staff nurses. And there are various multiple specialist roles with privileges given to our nurses who are working in the area. Why I am saying is all these nurse educators and nurse specialists and coordinators are prepared by the nurse managers or the faculty who are part of the College of Nursing. And this is just a glimpse of our hospital. Now I'm coming to the topic. Before I take it to the present, and explaining the model what we practice, I will quickly say the definition. A simple definition. Integration is a process by which nurse educators, that is, the nurse teachers, nurse practitioners, those who are in the clinical area, nurse advocates, or the nurse leaders, share their knowledge and competencies or the skills and their experiences in achieving common goals, such as one is effective student learning. That is ultimately our goal. Second one is improved patient care outcomes. And the third one is scientific advancement. As I repeatedly said, there are a lot of changes in the scientific and technology field. So we have to go with them. So unless you prove that this nursing practice is good, bringing about good evidence for our patient outcome, we cannot put it into practice. Hence, all three are very important. Okay, so it brings up this integration, brings about effective student learning, and that means a competent nurse, and that nurse provides care ultimately, which improves the patient outcome. And how that patient outcome improves? Through best practices. Those best practices are brought in by research by the nursing faculty and the nurses who are working in the clinical area. So the aims of integration are: it will improve the quality of nursing education, it will improve the quality of clinical training, ultimately contributes to the quality of healthcare in the country. Now, the concept of integration, as I told you, the nurse managers or the nursing faculty contribute to the clinical area. This arrow, this side, you see the faculty and the nurse managers contribute to student teaching in the clinical area and in the academia. So this is how both roles they take. That is how we call it as dual role. So the success story of CMC, as I told you, 1960, the beginning challenges, they started discussing with the nursing service staff. And as I said, there are a lot of challenges were there. And in 1968, we rolled out, and even now we are going, going through that, and we are following that. But we do face a lot of challenges currently because of a lot of changes which have taken place in the field of health. So how to take it through? We may have to modify a bit the integration model. What are the objectives at that time we put in 1968? The first objective is to achieve the optimum care for patients and sound education for students through effective utilization of qualified staff in College of Nursing. As I said, the MSc Nursing faculty, with their expertise, they can contribute in the nursing management in the clinical area, as well as teaching the students the clinical experience. And the second one is it improves the interpersonal relationship between the college faculty and nursing service staff. You know how it is. For example, the current nursing superintendent is Dr. Bala. Dr. Bala is a professor in College of Nursing, and she is currently holding the nursing superintendent post. We are going to call her now as a CNO, a Chief Nursing Officer of the hospital. And she has three roles. She has to take 20% of academic teaching, and most of her time, 60% of time, she'll spend in the nursing service in administration and taking care of patient care areas. And she has another 20% of her time spent for her scholarly activities. That means for doing research, for writing and publication, other activities, participation in conferences as a resource, paper publication, all those activities. So this is how we play the role. The junior faculty as the MSN tutor, assistant professors, they spend more time in the clinical area and very little percentage in the other components. So that is how we, work. And the second objective says that it improves the interpersonal relationship, because the nurse managers are with the ward in charges, are with the staff, checking their competencies, mentoring them, molding them, teaching them, and giving them counseling, all that. They are well accepted in the clinical area. So that relationship is built. And we also have a term of rotation. The nursing superintendent's position is for 5 years. Once she completes, she'll move to college, then another senior person takes over. So that's how we pool our, experiences in different areas. The third objective was to create a healthy environment in the clinical setting with less conflicts for nursing students. So nursing students learn the clinical skills with less stress, without any conflicts or any fight with the nursing service staff. We know in the beginning we had difficulty. Even now I see when I go for some of the colleges, when I visit, I find when the students go to the hospital, they carry all the things and go. And there are limited resources in some of the hospitals. They find it difficult to have adequate equipments and supplies to practice what they have learned in the college on a particular nursing procedure. So these are some of the challenges. So the conflicts will be less. And the fourth objective with which this model was introduced was to provide opportunities for involvement of senior staff and nursing service and College of Nursing at policy making level by serving on various committees. So the nursing service staff, the departmental sisters or the nursing supervisors, they are involved in teaching our students the nursing management, and some of them are good in some clinical areas on some clinical clinical specialist role. For so to say some example like stomach care nurse, one particular nurse will be an expert. So we can involve that nurse to show the procedure of stomach care to our nursing students. So that is how we exchange or involve the nursing service staff and the college faculty in exchanging or using the strength of their clinical expertise in teaching our students. And integration of nursing education and practice now in our college is like this. All these three, it's a Venn diagram. All these three are integrated, and it is, it has connected to one another: theory, practicum, and the research. So this is a model we practice now. And the specific objectives, again, some may be repetition: to facilitate student learning and quality patient care, to improve patient relationship between educators and practitioners, to create a healthy clinical environment, and to facilitate nursing students learning and the staff nurses. The staff nurses also get updated themselves. See, now there may be some staff nurse who had a training 10 years back. Now there is a new procedure introduced or a new technology, maybe ENR is introduced. So the nurse manager there who's trained recently will teach the staff nurses certain components of the competencies in the clinical area. So that facilitation is done in the clinical area. So these are some of the specific objectives. The last one, if you look at, there is an improvement in the critical thinking, planning and implementation of nursing care. And this is actually our overall organogram. This may not be very clear, but I will come to the next slide, which clearly speaks about the integration we practice. On top, we have the CMC director, who's the overall head of our institution. Then you find in yellow boxes, there are 5 administrators: the principal of the medical college, the dean of the nursing college, and the nursing superintendent of the hospital, the medical superintendent of the hospital, and the general superintendent of the hospital who takes care of the general services. All 5 of us are at equal, responsibility. And all 5 of us are part of the administrative officers, and we are involved in policy making. And whatever decision is taken in nursing superintendent's office, the dean is involved, including the recruitment of nursing service staff. The dean is part of it. Same way in the recruitment of College of Nursing faculty, the interview committee, the dean is part of it. The same way, there are many aspects. Education, when you say, when we recruit admission, we are in our admission board, the principal is part of it. Whenever there is a service component, whenever we plan something related to our students in the clinical area, expansion or starting a new course, we talk to the nursing superintendent, or there is a committee where we share which is the new course, how our students have to have experience. All that is shared with the medical superintendent, and we receive very good support from the general superintendent. So all of us are equal administrative officers. Then comes, we have deputy and additional deputy deans in the dean's office, and we have deputies and additional deputy deans in the nursing superintendent's office, and each one of them have their own roles or areas to take care. And they are, if you say for academic teaching and clinical teaching, all the faculty are responsible to the dean. And for patient care, all the faculty or the nurse managers are responsible to the nursing superintendent. Okay, so then comes the head of the departments. The whole service area is divided into heads. See, according to INC and university, we have 5 major departments. So we have 5 major head of the departments. But medical surgical nursing department is so vast. So we have divided into sub units, 8 sub units of medical surgical nursing. So that means we have 8 head of units, one overall medical surgical nursing HOD, and then 8 head of units. But the other departments are smaller departments. So pediatrics, OBG, community, psychiatry, nursing, foundation, they have one head of the department and the other faculty. This is how for academic teaching it is planned. And then comes the nurse managers. So nurse managers are all the MSc faculty who are responsible for a clinical area, at least 80 beds. We have a guiding principle. Each one of them will cover at least 80 beds, and the number of staff nurses, at least 150 to 200 staff nurses, they are supposed to monitor and supervise. And then we have the charge nurses. Charge nurses are for every ward, there is a ward in charge nurses, and our tutors also work with them. The tutors work with the charge nurses in the clinical area. Then we have the staff nurse. So this is how our model organogram for integration we follow. I can take questions later when during the concluding session. And the important benefits is we are able to provide quality education, we are able to provide quality patient care, and research we are able to do, and we are able to contribute to the society. And what have we achieved in teaching learning? Amplified long-term learning, and updated and practical learning. All the faculty, because they work in the clinical area also, their knowledge and skills are updated. Even now, I ask anything, a head of maternity nursing department, she'll be able to handle whatever complicated pregnancy, the role of a nurse in the clinical area. So the skill wise, all the nursing faculty are updated, and the practical learning, they learn from the clinical area as they teach the students in the clinical area. And at the same time, whatever difficulties and challenges they face in teaching the students, some procedures are outdated. So they come and share here. We have in the logbook these procedures, but nowadays it is not available. So we contribute to we write to the university, we write to the board of examination, we write to Indian Nursing Council. These are not available. This cannot be done. So we are able to contribute to curriculum planning by taking up this dual role. And it provides excellent clinical competencies and provides reality shock when the students go to the clinical area, or when the teachers go to the clinical area, because they are there in both the areas. It prevents the reality shock, and the teachers are the good role models, because not only teaching from the book, they are able to perform. So they are good role models for the students as well as for the staff nurses. And as I said, it strengthens the working environment in the hospital. They are able to contribute a lot to the nursing management in the hospital. And in the patient care, because of this contribution of the faculty in the clinical area, it improves the quality, it improves quality assurance and clinical specialization. As I said, many of the faculty who have specialized, they don't stop. We have many of them who have done specialized 3 months course from different parts of the country, or even from emergency. There is an expert, or as I said, stomach care. There are diabetic nurse specialists. Like that, the faculty themselves are specialists. So they are able to train the staff nurses and the students in the clinical area. And we are able, by doing research, they are able to bring in evidence-based practice, which are taken as best practice in the clinical area, and it is implemented. We have transformed the research into practice. And because they are there in both the areas, they know what are the needs of the nursing faculty to get updated. What are the needs of the nursing service staff to get updated. So we plan continuing nursing education based on the assessment and the felt needs of the nursing service staff and the nursing faculty. And good nursing manpower management. Because these nurse managers are supervising and monitoring them, you need not have so many people to monitor in the hospital services. So manpower cost cutting can be done. And ultimately, it develops and contributes to the development of the institution. And in research, the faculty are able to guide the students in research because of the clinical research, and many faculty research projects we were able to do, and many research collaborations with our medical team. Because the nurse MSCs have learned research, they're there in the clinical area. The medical team recognizes their expertise in the research. So they form as a team and they do interdisciplinary research along with the medical faculty. And they also do collaborative research outside the institution, outside the country. So it promotes research too, by taking up this dual role. And these are some of the pictures. You find the faculty, you find the same faculty teaching in the clinical area as well as teaching in this classroom. Same way during the COVID time, the faculty and the tutors, these are the faculty and tutors, they were helping in the critical care unit, teaching the nursing staff, our not only teaching our students and also teaching the nursing service staff. Now, I did mention in the beginning, the faculty is accountable for student education to the dean or the principal of College of Nursing, and for patient care of the assigned area, they're responsible for the nursing superintendent. And here you find the first picture is one of our deputy nursing superintendent teaching the nursing service staff, that is the nursing service staff uniform in the bedside. And the head of the departments are responsible for classroom and clinical teaching of students and patient care and staffing, budgeting and staff development in the clinical area. So head of medical surgical nursing department is responsible for clinical teaching organization, both assigning theory hours as well as clinical teaching, where, which area they'll be posted, all that. And then patient care, staffing, even budgeting for the department, how many staff nurses needed based on the SIU norms, is planned by the nurse manager and is given to the nursing superintendent. Even they are responsible for their own area staff development. And the organization chart brings all the faculty to go hold both the responsibilities together. And as I said, this we practice in the community area also. We have 5 major areas. We serve about 5 lakhs population. This is one of the unique nature. We have a College of Nursing community health program, which is a nurse-led primary care model, where it is managed only by the nurses, no doctors. It is only the nurse managers or the MSc faculty who are specialized in community health. Then we have the BSc tutors and the staff nurses, and we have few ANMs working, and we cover a population of 74,500. And these are some of the, you see that they are assessed at the village level, and then we refer them to the secondary level and then to the tertiary level. And we give them special training, and we follow this 3-tier model. For primary, you find primary care is by the nurse-led clinics and home care services. Secondary care, we make use of primary health center as well as CMC's outreach program. Tertiary care, we use the district headquarters hospital government and also the CMC departments. And this is a staffing in the community health. MSc faculty again play a dual role. I am the dean, I am a community health person, professor, but I have a population assigned and I am responsible. So I do go to the clinical area at least 2 days, and I do organize. I am also the head of the department. So I am part of the, today afternoon, I have a meeting with the department to plan for the activities for the next week. So every week we meet and plan for the student teaching. So we play roles like that. So nurse managers, and then we have the BSc tutors and the BSc staff nurses. Every BSc staff nurse is assigned a population of 3,500 to 5,000. 2 villages they take care, and we have ANMs to help with us in the field. So this is how the community health department integration takes place. And we have 4 components in the community health department: student teaching. And we don't stop with only going during the students posting. We continue the services. That is why we have the BSc staff nurses posted there. So they, even if the students are not there, the services are going on: clinic services, home visit services, and special programs. And we do take up a lot of research in the community health area. And we do train the government workers and other organizations who come. We get involved in ASHA training, especially now during the COVID pandemic. We were involved in training the government staff, as well as in the vaccination campaign. We were holding the government, along with government hand holding, we were conducting the vaccination campaign. 500 centers in Vellore district were manned by CMC staff nurses and students along with the government. And so we get involved with the government, and tomorrow also in the polio program we are involved. So like that, we get involved in various training and research activities, both inside and outside. These are some of the pictures of the nursery clinic, home care services. Okay, now coming to the evaluation, we did 2 evaluations. One is a qualitative study. Other one is going on now in terms of quantitative. So when we conducted the evaluation, the study population was the families or the patients in the hospital, and the students and the teachers, the administrators, nursing and medical. Okay, so we had a satisfaction survey, and we found the major components were, major outcomes were, there was satisfaction in patient care, and there was satisfaction in student education. The faculty felt satisfied because I taught that in the theory as well as I showed them in the clinical area, and I made sure that my students learned the core competencies what I taught. The satisfaction was there. Faculty and nursing service staff were well utilized to the fullest extent. This was a comment by the administrators of the institution as well as the nursing service administrative staff, the nursing superintendent. And everybody felt, a relationship, well established interpersonal relationship among all the nurses and medical personnel, and it still continues. So that satisfaction and relationship was strengthened. And students enjoy the healthy environment. There is no fight, the environment is very conducive for the students, and they don't undergo any stress in the clinical area. And the students have expressed that they had a healthy environment. And the nurse leader in nursing education and services are involved in policy making. Because of this role, every leader is involved in policy making. Today we have the inspection going on for the nursing excellence. You find all the nurse managers or faculty are involved in that. So, any decision making with regard to quality assurance and quality management, our faculty are involved. So they are involved in policy making. So these are some of the from the focus group discussion as well as some of the in-depth interviews, the important things which came out from our evaluation in early 1990. And the advantages are, after that we did not do any evaluation. Currently we are using a mixed method design, and we are assessing both qualitative and quantitative component, which is going on. We'll be able to give the findings maybe in another 6 months or 1 year. The other advantages are qualified faculty manage the clinical units, and faculty supervise, guide and mentor the charge nurses, staff nurses and students. And induction training, anybody entering the institution, the induction training, our nurse managers or the MSc faculty are involved department wise. If there is something related to obstetrics, the maternity nursing faculty is involved. If something related to pediatric nursing, the pediatric faculty is involved. And lot of in-service education is planned within the department. So if I am community health or if I am maternity nursing faculty, within the department for the staff nurses, the MSc faculty organize in-service education. Regular workshops and conferences, even the staff nurses are allowed to participate in the workshops. Today we have a workshop going on simultaneously for the staff nurses of Tamil Nadu, that is on obstetric emergencies. So our staff nurses are also participating, and there are few from, not few, 50% from outside. Which is accredited by the Tamil Nadu Nurses and Midwives Council. We have theory and hands-on experience. The skills are taught, the competencies are taught, and they are asked to do it. So that is how we help our staff nurses. And experienced staff nurses empower or mentor. The senior most staff nurses empower the nursing staff and our students. As I told you, in management, ward management, the ward in charges are involved. The nursing superintendent's office staff are involved in teaching the nursing management course, and in teaching the budget, supplies and all that in the clinical area. So that's how we make use of the service staff also. And there is opportunities for career development for nurses at different levels. We also give opportunities for the staff nurses working in the hospital to come up in their career. Staff nurses to do PBBSc, the nursing service sponsors them. They give them study leave to come and do the post-basic BSc and even MSc and even PhD. Same way, the College of Nursing faculty are given study leave. The tutors are given study leave to take MSc or PhD. So like that, we have opportunities for career development. And coming to the outcomes, the main outcomes are to the organization. As I said, because of the strengths of both sides, the organization develops and grows. And ultimately, as I said, you will be able to provide quality patient care, and that improves the quality of healthcare of our district, the state, ultimately the country. And as I said, the clinical environment. In the clinical environment, you have a very good outcome, learning environment. To the patient receives, with safety, a better care. And the student becomes confident and learns all that essential nursing competencies required to practice as a nurse. And to the nursing service staff, again, from the beginning, from the novice nurse, they are trained, mentored, and they become confident to provide quality patient care. These are the major outcomes of this model. Now, coming to the challenges, it is not easy. You might, because I'm speaking, it is very difficult to practice, which all of us go through, but you must know the other side challenges also. Lack of time for scholarly activities. Though I say percentage, sometimes we are tight. Sometimes we are tight with patient care areas, sometimes we are tight with academic teaching. But for all that, you need more number of faculty. God has blessed our institution, to tell you we have 100 MSc nursing faculty. So because we have our number of beds are also more, our clinical areas are also more. There are a lot of specialty areas, and most of our MSc faculty are specialists in some areas. Each one have specialized neonatal care nurse, or another person in breast care, another person in stomach care. So like that, each one of them MSc faculty have taken additional training, and they contribute to the clinical area. So their time is needed there as well as in student teaching. So we need more number of faculty. So one challenge is you need more number of faculty. Okay, that is important. And sometimes we feel that I don't have time. So what we do is we protect time for our faculty. Every HOD gives a half a day for the faculty to spend in the library, or to write for research, or to update their lesson plans, or to update their, whatever, if they want to take part in a conference or workshop, we give them at least 3 to 5 hours in a week, protect the time for their scholarly activities. And again, workload is huge. Sometimes, most of the times, all of us take home, workload to home. So that is a huge workload, and difficulty in balancing times at time with the family. And I'm not saying that you should forgo your family time. We have to balance work as well as the family. Family is also very important. So we should learn the time management, and whatever time, 8 hours, if you're working, make use of your time effectively for the work what is assigned. As I said, 8 hours, you plan in a week how you will do how many hours of teaching you have academic in the classroom, how many hours of student teaching in the clinical area, and how much time you will spend for your clinical research work. So like that, you need to balance. That's very important. So we don't expect you to work beyond the time all the time. Only when necessary, we tell our faculty, you may have to spend extra time. Otherwise, we encourage them to spend time with their family too. And again, most of our faculty have that commitment. Commitment is very important, because it is my students, it is my college, it is my institution. Ultimately, as a faculty, I contribute to patient care, being a nurse. As a faculty, I contribute to the future nurses of our country. So that commitment should be there. And at times we do have lack of cooperation. All 5 fingers are not same. So sometimes we face challenges, but our administration is very supportive, and they support us in various ways. I can easily take the call and talk to the medical superintendent or the director at any time. So we are given that freedom at the policy making level. Sometimes we face challenges with some people, but it is sorted out every now and then. These are the challenges or pitfalls we face. However, we can overcome, with the support of the institution. That is very important. The nursing service department and the administration should support the nursing college, so that we will have this integration being put into practice. And how do we implement this process for the future? As I mentioned, now in the recent past, I've been sitting in the ICN meetings, and in some of the meetings at the country level, at MOH, and even some of the, discussions with regard to future nursing. So everywhere, everybody, raises this. Recently, I attended a workshop on leadership for change project by ICN. Everybody, the whole world is talking about there is a theory gap practice. There is a theory gap because nursing college, the school is separate, and hence, it is not taught properly to the students. So from the medical team there's a complaint that the students are not competent. In one of the meetings, one of the senior most joint director was saying, your students do not, do you teach nutrition? Your students do not know to educate a diabetic patient. So I had to raise hand and speak. It is there. It is there. But the implementation part somewhere I don't know, maybe most of I find around more than 400 participants. I'm so glad that I'm addressing to you all. Whatever is there in the curriculum, we make sure that, including me, we need to teach our students and see that they practice that in the clinical area. So they contribute ultimately to the healthcare. I'm not saying we are not doing. Each one of us have a lot of challenges in our own working areas, either in the college. Some of you might say that we do not have enough faculty. Some of you might say that we do not have enough clinical area. But we have to work together and see that all that is put it into practice. So I will say that it is with us as nurse educators and the nursing service providers. It is with us to improve our profession. And the implementation process is a challenge. If any of you, everybody is not successful. So wherever, when this topic is it comes up, I will immediately accept. I know today is a busy day for me. I know today we have this certification. I'm called for a meeting and we have a workshop going on. So many things are going on, but still I accept it because this is a passion for me. To bring about the future nurses who are competent to provide safe, quality patient care to our human population. That is very important. So we need to create this awareness and commitment to introduce this integration model. That is the first step. We need to educate our administration wherever you are. And then, as I said, there are challenges. You may not be able to fully incorporate, maybe to some extent at least. Make sure that your teachers spend half a day at least in the clinical area and they are part of the decision making in the clinical area and not just sticking on to the college or the school alone, so that they get updated in the practice area as well as in the academia. And dealing with resistance and gaining support, this is a challenge. So you have to really, there will be a lot of resistance. CMC did face that. 7 years it took for CMC for that.
Hello, ma'am. You are not audible, ma'am. Hello.
Ma'am, your voice is not audible.
Is it audible now?
Can you hear me?
Yes, yes, ma'am. Yes,
Yes, ma'am.
To conclude, as I said, past, what all challenges, how we started, and then we have been practicing, it is continuously being, it's a success, but we do face challenges and we are overcoming the challenges. And I would suggest follow the steps, what I said. You have to have the nursing service department and the administration with you as nursing educational institution. All three of you together, we need to sit and how it need not be the CMC's model. You can modify and plan, and ultimate goal is our students need to learn in a conducive environment and our teachers need to be updated, and we have a very good curriculum in front of us and that has to be implemented properly so that the students are competent and they are the future nursing workforce in the country as well as across the globe. So that's very important. So quality patient care and safe patient care is very important, and make use of the highly qualified teachers in the education side in the clinical area so that our nurses also will improve their level of thinking, planning and implementation of care. And hence, the main issue is bridging the existing gap between the nursing service and education. And that can be done only by the concept of integration. So how you will do, I don't know, because it's in your hand. So integration amalgamates education, practice, and research, which is best for knowledge generation and dissemination, which can actually bring the real transformation in nursing that today's complex healthcare demands. So it is a pragmatic model for future healthcare in India. Why not give a try? It's with that thought I am completing. But to implement this model, there are some guidelines which are already put in. If you visit Indian Nursing Council website, it was developed by the nursing faculty of College of Nursing, our former dean, Dr. Punita Lilarasu, and some of us have given input into it. So this is if you go through that, in the main page itself, it comes, the integration of nursing, concept note on integration of nursing education and practice dual role, where if you turn to page number 9, it clearly says the guidelines for implementing the integration model. So it tells how to step by step go through the integration model. Maybe some of you are from the government setup. It also tells how to introduce that with 9 steps implementation guidelines based on the IPH standards and the SIU norms. This particular guidelines are developed. So because the time is limited, I'm not going to take you through. So if you are planning to develop this model, you can go through the implementation guidelines. If any of you are interested to come and visit and see how we do it and interview some of our faculty, you are welcome to do so. Next week, I am getting one group of faculty coming from one of the College of Nursing from Chennai to learn from us by directly interacting and looking into the, some of this specific areas. So with this note, I will conclude. Maybe I can take questions. I have another 7 minutes more.
Thank you, madam. We are expecting the participants. You can ask the questions if you are having any doubts from madam.
I think there was one about they want to come to the institution as part of administration visit. Currently, government definitely will permit, and private institution, depending on the availability, only we give, because we have visiting students and visitors from all over India countries. If there is a slot, definitely we'll give. You write to us, we will definitely respond. And somebody wants to do PhD, MGR University has a guideline that you have to be working in the institution here. So CMC also has that. However, under the National PhD Consortium, you can do, and our faculty, we are the nodal center, our faculty can guide you. And anybody else raised hands? I can't.
Ma'am, good morning, ma'am. This is Vadivu calling from Silvassa Nursing College. Thanks a lot, madam. Such a wonderful session. It has given a lot of insight to us. I just have 2 doubts, ma'am. One, you have this additional training of your own faculty. You said, no, madam, like a trauma care. Can you give us some resource from where we could get so that we also can implement the same in our institution?
You're asking for trauma?
Not only trauma, madam, any other, you said many other training session you said, no? So
we send our faculty as part of faculty development. We have a program by the institution called Junior Fellowship and Senior Fellowship. Okay. So they apply for this and send them to outside country. They go to US, UK, wherever it is. Recently for stroke, had 12 weeks of training and came. And even emergency trauma nursing, last 2 years back, before pandemic, one of our MSc faculty went to US and came back. So CMC supports that, faculty development, medical, allied health and nursing. So if any of them are interested, they apply for it and we pay for it. So most of them have got training from outside. Stoma care is from Tata, Mumbai. Palliative care is from here. Like this, we identify different areas and we send them out.
That's great, ma'am. Thanks a lot, ma'am. Ma'am, I have one more doubt, ma'am. This,
Yes.
how do we manage the timings of the faculty when we are taking a dual responsibility? Already you have answered in the conclusion also that though we are having a lot of difficulty, somehow we have to. But as you mentioned, how do we manage our timings? Is there anything you have separate model like morning and evening? How do you manage?
Time planning of the day or for a week. Next week what is going to take place. So accordingly, see, to me, my HOD taught when I was a junior faculty. Saturday we plan next week, Monday morning, what will I do? Afternoon, what will I do? Tuesday morning, looking at what programs are there. If teaching, I will put that 8 to 10 is my theory teaching, and 10 to 12 what I will do. And afternoon I might visit to my clinical area. Or afternoon, if I have classes, morning I will be in the clinical area when the students are there in the clinical area. So like that we plan. As I mentioned, the senior faculty have different proportion. As I said, 60% of their time maybe they will administrators will spend for administration, 20 for clinical area and 20 for scholarly activities. That percentage changes. Maybe the middle level manager, maybe an associate professor will have 50% classes and 30% in the clinical area and 20% in the scholarly activity. So in a week, I plan like that. So sometimes it may not be possible. Some new things will come up. So it is all in your hand. 8 hours in a day, how effectively you make use of it. That's all in your hand.
Excellent.
Thanks a lot, ma'am. Thanks a lot. Wonderful.
Madam, I am having one more doubt. Can you tell us about nurse-led primary care model?
Yeah. So here we have adopted 25 villages for providing nursing experience, community health nursing experience for our students. So we have taken permission from the Directorate of Public Health that these villages are adopted by College of Nursing. So we have a permission, and this was started in 1987. That time I was there. So initially we did a baseline survey and we did a need assessment. Based on the needs assessment, we put down objectives. But the main objective is to provide clinical experience for nursing students. We have a whole lot of procedures to be shown for our students. And all that requirements we meet here. So with the needs assessment, we put priorities. When you go to the area only for giving educational experience, the patients will not have confidence. So we have taken service component also. So we started conducting nurse-led clinics. So all our nurses, once they join, they are given training in OBG and pediatric care, assessment skills. We update them. Community ophthalmology, community psychiatry, those essential core areas, we give them additional training by our doctors so that they are, empowered to manage. So they do the assessment at the primary level, and our medical superintendent has also vouched or authorized a standing order. Some of the investigations we do, like hemoglobin checking, RBS, all that we do it in the community, and some assessment they do, and they are experts in doing the clinical assessment, and they do the primary diagnosis, and we have a list of medicines which they can prescribe for what conditions. That is a standing order, and which is authorized by our institution. So they supply medicines. We take medicines to the centers, and again we work community partnership. Every village has a center. It's not CMC center. The center is given by the community. We have a village advisory committee. We work very closely with them. And we also work very closely with the government staff. Every Tuesday when there is a review meeting, we work with 3 primary health centers. So our nurse who is responsible for that area, the middle level staff or the MSc faculty attend the review meeting. So we give the report, they share with us what is done. So it is a collaborative work in these 24 villages. So that is how we are able to move about. And not only that, we have lot of income generating programs for the community, lot of capacity building, empowerment programs for them. And we involve our students for the NSS program in that area, community orientation program in that area. So we provide home services regularly for the high risk as well as for some category. We provide clinic services, and if they need next level of care, we refer them. And we refer them to the CMC departments, and our nurses go speak for them, or we have a referral slip that is recognized in the CMC departments for their payment and for other assessments. And the nurse liaises. And every village, we have village level worker who liaises between the community and the nurse. So this is how we have the nurse-led model. If any of you want to come and visit, you can come and visit and learn this model.
Thank you, madam. Madam, are you having any student exchange program for the UG and the PG students?
Only for PG we have, UG we don't usually encourage. As I said, no, it depends on the workload. You know, in a year or in a month, what programs are coming. And, you know, like that, if it is available, definitely we'll give you. For observational visit, definitely we'll give.
Okay. The duration of student exchange program for the PG students, madam?
1 week.
Okay. Yeah, thank you, madam. I hope we are coming for the end of the session of Dr. Vatshala madam. So we understood the background of integration model in CMC Vellore. CMC Vellore is one of the leading institution in all over the country of India. So we have also adopted the dual role of Vellore pattern, but we are having lots of hurdles as well as the challenges. So we are under the process of piloting of CMC Vellore model in our institution based upon the dual role. So we are in the pathway to achieve our goal. So, but still, the teaching clinical education, we are having a lot of hurdles from the staffs because the negative attitude from the staffs, because we are the teachers, we cannot touch the patients, we cannot give, we cannot teach the bedside teaching. These are the issues we are facing, but we are overcoming to that. Our policy makers, they are the great help for us. I think we will achieve in another 3 years to the modified model of Vellore pattern. So I'm thanking you, madam, integration of nursing education service and the research. So we are overcoming the gap of education and the service. The third component we will be achieving in another 1 year. So the another new role that we have learned from your role model, madam, that is the nurse-led primary care model that we are going to develop with the consultation of our experts in the university. So we learned from your session, madam, all over about CMC Vellore. So I'm thanking you, madam, and will adopt to the pragmatic model for the future care model of India. So then we can improve the quality of nursing care. That is the end outcome that we are getting, and we will generate the evidence-based nursing services. So where our institution is situated in rural part of the India, so we can give the rural care for all the patients. They are ignored, they are left over due to pandemic. So then we can enhance the nursing services in India. So thanking you, madam, you accepted our request. So then we can, we will see through in the future also. So we will contact you. So then we were in CMC Vellore in the year of 2017. We have taken the training of Dr. Pratap Tare in systematic review. So we were encouraged because of systematic review. We have learned some of the technology, the software, how we have to generate the evidences. So we are thanking you once again, madam. God bless you.
Thank you, Professor Jai Gauri. Thank you for the opportunity. I am so delighted to hear that you have started, you know, putting it into piloting this model. As you said, there will be challenges, but we can face. And as you rightly said, you can modify and start implementing. Wish you all the best. God bless you.
Thank you, madam.
Thank you, ma'am, for sharing your deep knowledge with us. Your session was full of valuable knowledge. Thank you so much. Now, It's the time to second session. The second session is on challenge and issue in integration of nursing education and competency based clinical practices, which will be dealing by Dr. Lukima Saikia, lecturer, Regional College of Nursing, Government Assam. The chairperson for this session is Professor Archana Moria, Child Health Nursing, Srimati Radhika Bai Meghe, Memorial College of Nursing. She is having 21-year experience in nursing profession as an educator, teacher, researcher, facilitator, convener, and PG teacher. He has also having experience about HOD from 2013 to 2018 for 6 years. She is a PhD supervisor. She is member of TNAI. She is PhD guide and UG and PG examiner. She is having total 96 publication. Out of this, 81 are original article and 15 are review article in Index Journal, Web of Science, and Scopus. She also as a speaker and chairperson in various national conference and workshop. She awarded as a meritorious staff of the staff of year in pediatric nursing department. She presented paper and poster in various conferences, and she won first prize for poster presentation in national conferences and also won first prize for scientific paper presentation in international conferences. I request Professor Archana Moria ma'am to introduce our esteemed speaker. Thank you.
Good morning. Good morning to one and all. I am really privileged to take the opportunity chair of this session. The theme of the session is the challenges and issues in integration of nursing education and competency-based nursing clinical practices. Someone quoted, the leadership, it is the capacity of the translate vision in the reality. So I am pleased to introduce the speaker of similar personality of this session, Dr. Lukima Saikia. She had professional journey around 24-year experience, including the clinical and teaching. At present, she is working in the lecturer at Government Regional College of Nursing. She worked as a various posts as a tutor, assistant nursing superintendent, associate professor, as well as the vice principal. Her qualification, professional qualifications, she did their BSc from the Assam in 1999 and MSc from the Chennai in 2005, and she completed their PhD in 2015 from Guwahati University, Assam. Madam also done some postgraduate diploma in the hospital management, Madurai, Chennai in 2010. Now, Madam plays as the guide of the Mizoram University and counselor of the Indira Gandhi Open University. She has participated as well as conducted the various workshop and conferences, and she is the life member of the TNAI, SOMI, NRSI, and she has published 25 articles in the various journals, as well as she presented the paper and poster in the various conferences. Madam is the winner of the scientific poster in the SNA conference. It is organized in the state level, Assam. So now I call upon Madam Dr. Lukima Saikia for deliver their speech on the challenges and issues in integration of the nursing education, competency-based clinical practice. Now, ma'am, welcome.
Thank you, Professor Archana Madam and SRMMCON. First of all, I would like to convey my regards to all of you for wonderfully organizing this national e-conference and giving me this opportunity from Northeast corner of India. So I'm so much thankful to you all. So let me share my screen.
એ છે ને તમારું તમને પેટમાં ગુડગુડ એવું થાય છે? હા હા, એ ટોક્સ થાય છે ટોક્સિન એવું નીકળશે ને બહાર.
Is it visible to all?
Yes, ma'am.
Okay. So topic which has been given to me is the challenges and issues in integration of nursing education and competency-based practice. So this from the Vachala ma'am, we came to know that a lot of challenges are happening in day-to-day practices of nurses. So when we talk about the terminologies, so we say that a call to someone to participate. When we talk about challenge in a competitive situation or fight to decide who is superior or inferior, ability or strength. That is like we nurses, we are facing every day in our day-to-day practices. We are facing a lot of challenges, and during this 2019 pandemic, we came to know that what are the challenges we faced. Issues are an important topic or practice, debate, or discussion. Then competency-based practices is provide safe care in a manner that views a larger perspectives of the patient and an ability to accurately assess and critically think through the best options for care using evidence-based practices. This is very important aspect. So coming to the introduction, nursing in 21st century is confronted by various demands. So first is what? That elevating numbers of elders, patient and critically ill patient, that we know that our numbers of elderly patients, because life expectancy of Indian population is increasing, as we all know that, and this is the biggest challenge in day-to-day scenario. Increasing healthcare expenses, that also we have seen during the 2019 pandemic, that healthcare, some of the patient in public sector and not only public sector, private sector, they have to pay a huge amount of bill during this COVID-19 pandemic. And increasing deficit in nursing staff and nurse educators and the shift in the age of the nursing workforce. Definitely, nurses shortage is the biggest problem in our country, and not only in the country, in the globe. So what are the challenges facing in nursing education? So aligning education with the practice environment. As we know, when we move a car, we see the alignment of the wheels. So why alignment is important? Because we know that when our wheels are in the same alignment, we can safely do the journey. Same way, nursing education has a significant impact on the knowledge and competencies of nurses, all healthcare providers. So what we teach in the theory has to be put in the same alignment in the practices. And we also believe that the nurses which we prepare from the graduate level, they are enabled to meet various demands, needs as a leader, and advanced science that benefit patients and the capacity of health professionals to deliver safe, quality patient care. Then curriculum enhancement. This is very, very important, because always curriculum is prepared, nursing curriculum, basically it prepared from the societal demands. So continuous curricular modification are an essential phenomena in nursing program, and in order to level learning with rapidly evolving professional practice. And now also we are going to introduce our CBCS system-based, that a new curriculum which is having different modules also we have to teach to the student, and this is society's demand at this 21st century. So we are in need of curriculum enhancement. Even faculty members gain insight on the patient's feedback on their clinical placements by the end of each year, or if we have a semester system, through the individual and group discussion using interpretive, descriptive, qualitative research methodology, which already Madam, the previous speaker, has spoken about what is the importance of having research. Then when we prepare a nursing program or a curricula, that it aims to prepare nurses who are able to deliver safe and high quality care and would be able to adapt to the evolving environment of practice. Because yes, we are societal demands are so much nowadays, so we have to see that our curriculum, our program has to par with that excellency, and we have to be able to prepare the graduate nurses to deliver high quality care to the patient. Then nursing pedagogues endeavor to expose the students to various learning experiences to make sure that they receive their information through multiple channels and would have access to the best available evidences. And this strategy takes a lot of time and energy from the nurse educators and might face multiple challenges. But we as a nurse educators, we always try to give our best to our students so that they get the knowledge from different channels. Nursing as a part of integrated healthcare force. This, as we nurses are recognized as an integral member of the healthcare team. So this is very important that the careful cooperation and team harmony yield higher patient containment, lesser hospital retention, reduced medical stay, enhance patient healthcare results among individuals, increasing healthcare, reducing the healthcare expenses with chronic illnesses and diminish mortality rate of hospitalized patient. So we have to work with the team. This is very important, and this is will help us to give a better services to the patient as a whole. So, and we are also integral part of it. Then faculty development programs, as Madam has said, this is very, very important because our curriculum is enhancing and our different modules are going on. And so faculty development is very important. So we faculties has to get updated knowledge by attending some of the conferences, workshops, and training we have to undergo. So quality education relies largely on well-trained and competent faculty members. In our organizations, in our nursing organizations, if our faculty members are not competent, so we cannot give the best quality education to our students. So competency is very important among the faculty members too. So faculty development and faculty vacancies are demanding challenges in nursing education. Yes, we know that as Madam said, CMC Vellore is very lucky to have 100 faculties. But I know that most of the government and the private colleges, still we are having so much of shortage of faculties, and vacancies are lined, and we are in demand of these faculty members. And inadequate capacity in nursing institution, increasing requirements to take part in non-academic activities, university activities, and relatively low pay are a primary contributing factor to the deficit of nurses. And the lack of nursing faculty is a primary causative factor of the capacity restraint. So we are facing a lot of challenges in the nursing development too. Then educators need practice to allow them to integrate theory into practice through synchronization of theoretical themes with the practice courses, as well as evidence-based educational strategies more effectively and equip nursing students with the competences demanded in 21st century healthcare environment. So synchronization of what you teach in the theory, definitely that has to have a very good synchronization in the practice area. So what we teach in the theory, if it is not practicable or if it is not practiced in the clinical areas, then our patients are not going to be benefited from us. So having synchronization of theory and put it into practice is very, very challenging tough for the nursing faculties as well as for the students too in our curriculum. Then technological challenges for nursing education. Yes, this 2019 corona pandemic has taught us a lot of this kind of technological challenges. Even now, we are not able to meet physically for the conferences. You are organizing an e-conference. So this is a really tough challenges for all the faculties or to organize a 2 days this kind of e-conferences, because the amount of work you have to put for physical is more than for this e-conferences. So technology has an influence on our lives, on practice, education, management, and research. So now what happened in nursing education, we are outcome-oriented education nowadays, and it is currently being highlighted rather than process-based learning. For instance, through skill-based techniques, evidence, and based techniques education, providing students in a rich learning journey, unlike former models of formal lecturing, and incorporating evolved learning technologies in many programs. So earlier, the teachers were only giving the lectures. Now we are not doing only the lecturing, different teaching methodologies we are adopting in the classroom so that we can make the class more interesting, and we are outcome oriented. All these styles share one major challenge, that is how we merge the art and science of caring together with the easily accessible technology so that caring persists to be conversed on humans. This is very important aspect. We know that nursing is a professional combination of art and science. So how we merge it and how we put base to the humans, this is our challenge. Then technological challenges for nursing education. Again, educational technology is the employment of evolved models of educational journey, and for the former decade, this has incorporated using web-based education in both live classes and classes uploaded to the internet for later access by the learners. This we did during the time of pandemic. We all have used web-based education. We have given, we used to take the classes in online, and what we used to teach, that also we used to upload in the YouTube so that our students can access our class after our online classes too. So it also evolves in electronic references such as ebooks, a multitude of internet hosted material, computer access and broadband internet services within the class, and IT rooms, smart boards, video conferencing, and so on. So this we all are having, and this is like now digital library concept has came. So we were earlier depending on the books which we touch physically. Nowadays, the digital library concept is coming. Then IT rooms are there in all the colleges. Video conferencing room is available. Smart boards are available in the classroom, and Wi-Fi facilities are there in all the colleges. Then educators have a double-edged role to include the appropriate employment of technologies in education and train nurses to employ technology in clinical practice. So definitely, so now you know that 1.5 Tesla MRI machine has came, PET scan machine is used for oncology. So these are challenging for the nurse educators, that how we teach the students that how you prepare a patient when you send for PET scan machine to undergo a diagnostic procedure, or for 1.5 Tesla MRI machine. So these are the things. It's a challenge for the nurse educators, but we have to train the nurses to employ the technology in clinical practice too. Then despite the changes taking place in the nursing milieu, nurses are still served at the center of healthcare system. So that means we have so much of importance. Therefore, nurses must be properly trained to care for the human spirits, cultures, and societies, educated in both the scientific and technical aspects of care, who provide holistic caring. So we are always talking about the holistic concept. We are not focusing when the patient is coming to the hospital. We have to teach the students that you are not focusing on the patient on the physical part, but the physical side. You are also integrating all the concepts together, the different dimensions, the mental dimensions, spiritual dimension, emotional dimensions. So as a whole, the holistic caring, we have to teach them. Then cultural diversity in nursing education. Yes, we know that we nurses, we are not biased in providing our services. Same way, there is the innovator for enhancing the diversity within the nursing profession in light of the increasing influx of immigrants.
Your voice is not coming.
Yeah, are you getting me now?
Yeah, no.
Okay, so there is a need for enhancing the diversity within the nursing profession in light of the increasing influx of immigrants, minorities, and expanding globalization in order to satisfy the demands of our evolving communities. So we have so many minorities people, we have immigrants and immigrants from different countries. So we have to prepare our student nurses that they are able to provide a diverse cultural-based care, quality care to the patient. Yet various obstacles they have to face the accomplishment of diversity outcomes within the nursing educational programs. Diversity stimulates educators who are attempting to enhance student learning and achievement. Now, economic challenges. Tuition fees pose obstacles to prospective candidates where the economic condition is very poor in a state or a country. Yes, definitely. There are so many prospective candidates who wanted to enroll in the nursing program, but they are not able to pay the tuition fees if they are not selected in any government care sectors. Moreover, program location can be hindrance to nurses who are placed bound by responsibilities to support family and provide income. So sometimes because of that also, they cannot come out from the home to have enrolled for a nursing program. Nursing programs are less available in rural areas despite the increased and crucial necessity of such program in such areas where nurses have to be satisfied with longer shift for less pay. This is also a real fact that we have so many institutions in the urban areas, but we rarely go and we used to establish any like nursing colleges in the rural areas. The nurses who are employed in hospitals find it difficult to continue their educational career and specialize in certain areas of nursing, as employers usually have to pay replacement fees in order to for them to attend their classes, thus posing an added economic challenge. So those who are really, they have to support their families or they are working in a private sector, so they don't get pay when they go for higher education, so they have to leave the job and they have to go for continuing the higher education. So but in the government sector they get some kind of deputation, so that is fine, but otherwise that also a economic challenge for opting higher education by some nurses. Then options for addressing challenges. So gap between nursing education and the practice for the 21st century been rapidly widening. So education shall have the scope of practice, informations and other alternation in healthcare delivery systems. So there is a gap. Even Madam said there is a huge gap in the theory and practice. But how we bridge this gap is very important, and these options should be always open. So what we do in our college, where before placement of the students in the clinical field, we is to go and meet with our clinical objectives. We meet our nursing leaders in the hospital, like nursing superintendent and the nurses in the ward. So we used to say them that these are our clinical objectives and these areas our students are going to be posted. So we used to have a common meeting before placement of the students in the clinical areas, so they also feel cordial with us, and that way we also give them freedom that if you feel that you want to take some classes for the students when they are in the clinical field, you are most welcome. So that way we have to have a very good collaboration, otherwise they feel that they are in the college and they are just coming for student supervision and they are not giving us importance. So that should not be there. So if we have a collaborative meeting before placement of the students, then this kind of gap can be reduced. Then education favors the incremental. Yes.
Okay, ma'am, continue.
Hello.
No problem, ma'am, continue.
Okay. Education favors the incremental adoption of change, whereas the practice setting is more agile and thus can swiftly incorporate change. So we have to say that which is fast moving organizations. Some organizations are having some traditional practices, but we have to see that we are not have to be based on the traditional practices. We have to see that organization, we have to place the student in those organizations who has modern technologies are available where they can practice it according to the need based in this 21st century's demands. Then academic and practice partnership. This is very important. So when we create a partnership with a wide range of community organizations, we have a lot of community organizations, and providers can instill that interest and offer broader learning chances for nursing students. So like we have Lions International Club that also provide this community organization, also always working for the betterment of the community. So when we go there, if we can have a partnership with them, so definitely in the community side, we can provide better services to them, because we have a definite placement of students from the second year to fourth year in the clinical rural community as well as urban communities. Then while faculty may consider that an optimal clinical training experience is one where students are adjoined with the instructors in a 1-to-1 ratio with patients inflowing at present appointment times, establishing partnership with hospitals and care providers in various clinical settings and environment might be valuable. So we always have to, if we want to provide quality service, education to the students, definitely we have to say that how we give one-to-one ratio with patient. But it is not at all possible because we know that there are a lot of hindrances and our staffs are very much shortage. Then academic practice partnership, the establishment of community relationship with a service learning framework can offer creative chances for students to interact and take part in health awareness, physical and mental health evaluations, and intervention with people with no access healthcare services in a given setting. That we do when we are posting students in the rural and community practices. We provide health education. We do need-based procedure to them. We do the physical assessment of the family members, and that way we develop a very cordial relationship, and we also develop some health awareness program among them. Then cooperation between Educational Institute of Nursing and hospitals or clinical practice setting is a method of resolving complex conflict confronting educators and clinicians. This is very, as I have said you, that before placement, you should always have a meeting with the hospital authorities from the nursing side or the doctors who are HOD of the, suppose you are going to place the students in the surgery or medicine ward. So you can also have a talk with the HOD of the medical or surgical department along with the in-charge and the nursing heads, because that will give you a very good cordial relationship, and they will give you importance when your students are placed in that particular areas. The internship, the transition from the students to novice nurse is a strenuous one. Yes, we know that because what they learn, and when they go to really practice in the practical field, so it is strenuous for what? The novice graduates are confronted by various obstacles when adjusting to the workforce. To resolve this, an increasing of patients with access and various deficiencies, inability of teachers, instructors, and coaches, age variations within the workforce, performance anxiety, and bullying. They face a lot of these things. And now you just imagine this 2019 pandemic, 2 years for the 30 and 40 student. They didn't go to the clinical areas, only online, only final year students were allowed, but other students were just sitting at home and they were doing the online classes. So how, what type of confidence they will develop after passing from this course to practice in the clinical field? Definitely it will be very much strenuous for them, because they hardly had clinical practice exposure in the clinical areas or any healthcare hospital settings. So novice nurses start out with immense pressure, and with the lack of the proper reinforcement, the pressure of this adaptation can sum up to an elevated turnover rate for new nurses within their first 2 years of recruitment. So sometimes they feel so much pressurized because they are not able to put it into practice, what they have learned in the theory. So that way, the turnover rate also sometimes it is very high in the private sectors. Then development and test innovative program models, technology models. Information technology can promote the conveyance of course materials, streamline course management, enhance availability by students and faculty, diminish expense, and enhance educational result. So innovative test program, that is information technology, definitely we are using, and we are getting a lot of modules and materials available in the websites. Then information technologies have a broad spectrum of implementation of nursing programs, definitely involving e-learning, simulations, blogs, and online scholarly and research journals. So we are also nowadays getting online journals. So technologies such as clinical simulation and e-learning can aid organization invest in assets and thereby broaden teaching abilities. So that all the organizations are now they're trying the level based. Earlier we had only the laboratories. Now we are going to we are almost all of the institutions are trying to set up some skill labs along with the simulation lab. Then simulation, yesterday I have seen that one sir has taken already. So simulation has gone high tech, enhancing its efficiency as not only as a potent tool for novice nurses, but for experienced nurses as well as who are interested in improving their advanced competencies. So, in nursing, always we have to update our knowledge and our competencies. This is very important. So suppose for where we can do the simulation at college in the lab, simulation lab, that suppose endotracheal tube intubation we can learn in the simulation, and that will give you so much of confidence when you go and practice in the clinical area in the critical care units. So like that, so many procedures are there where we can perform in the simulation lab, and that really boosts up our confidence. So simulation is a powerful educational strategy which can enhance patient outcomes and the culture of safety among nurses. When we are practicing ahead of our real practice, definitely we are confident and we are maintaining also the safety. The numerous studies have showed that nurses participating in simulation have displayed improvement skills such as detecting a deteriorating patient condition, classifying emergency patients more meticulously, dealing with stroke patients, functioning cooperatively in obstetric settings, and more. So this is very, very important to have a simulation lab practices before we put our students into a real clinical setting. Then observers interprofessional education, it is called IPA. Observers to nursing education systems around the world attain that nursing students are tutored by various healthcare professionals at clinical settings. As I say, that nurses are an important integral part of healthcare team members. So even when the doctors are giving round, many a time I have seen that our students used to attend the doctor's round, and doctors used to teach them a lot of clinical diagnostic based procedures. Then they also treatment modalities they used to discuss in front of them. So, and that's why Cohen Baker maintained that nursing education in the 21st century needs to sustain interprofessional education to nursing students. This is very important. It is not necessarily that only nurses, nurse educator only have to teach them in the clinical practice areas, but other professionals also, whenever it is possible, they can also teach our students in the clinical setup. That is called interprofessional education. Then what future challenges the nurses are going to face? Future challenges to nursing education include ensuring that nursing students be instructed in the care of an increasingly non-hospital-based patient population. Yes, definitely, we are moving our care to the community-based practices. The development of new electronic platforms to enhance the learner's educational experience, the art and science of collaboration, and finally, maintaining integrity of scholarship in the online learning process. While the shift has been subtle from hospital-based care to an increasing emphasis on community-based care, some nursing educators feel that nursing schools in the future will need to produce graduates that can provide competent care to a diverse patient population. This will require broad education in symptom management, community-based point of care testing tactics, and the ability to systematically assess chronically ill patient for system deterioration. And for a hospital-based patient, this is a complex task for the new nurse, and it can take months to develop this skill, but it can be very challenging for a new nurse to provide this level of expertise to a community-based client. And now all of us, we know that the middle level healthcare provider MLHP course has integrated with our community health nursing syllabus from 2020. So then and there, when a student pass after 2020, the students who are passing, we from the college, we issue a certificate that they have also integrated MLHP course they have completed, and on the basis of that, they are giving the post of community health officers in the health and wellness centers. So that means we are moving towards the community-based practices by recruiting the graduate students in the community health officer post. Then coming to the issues, the curriculum development in nursing education is based on competency and focusing on the output of the students. Definitely, when we are teaching our students, so what is the outcome we are getting from it? It is important, and it invites students' participation and responsibility for nursing. This is a very common issues, that how we motivate the students to participate in the study. This is the biggest issue. Then socio-demographic, cultural diversity, economical, political changes, and global issues. So increasing aging population, in the beginning slide I have shown, increasing multicultural ethnic diversity requires increased learning. Immigration conflicts, protest consequences for access and healthcare. Then global community, that is globalization, health issues, global nursing networks, then social and economical political changes, multidimensional content, client care and clinical learning sites. These all are issues now. Then rapid knowledge expansion, increasing use of technology and informatics in education and practice. So which one to choose? Choosing the most effective electronic and technological option. Then information overload, virtually unlimited global resources, global research opportunities are an issues. Then identifying current and accurate information. Sometimes what happens, material rapidly outdated. So which one to select best is a issue now. And expanded expectation, limited time, rapid response expected, little time for reflection. Then expansion of nursing informatics, content and skill development. Then practice competency outcomes and evidence-based content. Learning focused on core competency, practice competency outcome, professional skills beyond technical psychomotor skills, core practice competencies, multiple conflicting version, which one to use? So this is an issue. Then integration of evidence-based standards, research findings into practice, emphasis on critical thinking, problem solving. We always discuss in the classroom, critical thinking, problem solving. This is always, it's becoming slogan for us as a nurse educators. So changes in standards and ensure patient safety is also an issue. The performance-based competency, that is learning and objective assessment methods, that is multiple teaching learning methods, interactive collaborations, in-class and out-of-class projects, problem-based learning, increasing self-responsibility, accountability for learning and competence, interpersonal learning using electronic devices, media to access resources. Then competency assessment based on performance examination, specified portfolio documentation, standard-based assessment methods, and emphasis on patient safety. Then patient-centered care, engagement, safety, and privacy. All expect value, quality, individual respect, consideration, attention, and privacy issues. Patient initiative for involvement and protection, balanced standard and preferences. Increased litigation, medical nursing errors, focus on safe and competent patient care. Increase individual responsibility and accountability for learning and practice. This is like, no, we have to teach the students that whatever they do, they are not dealing with a machine, they are dealing with a human being. So whatever they do, they are responsible and they are accountable for each and every single procedure they done on the patient. So that responsibility and accountability we have to teach from the classroom itself before we put them into practice or the clinical setting. Then increasing shortage of nursing faculty and nurses. This is the biggest issue. Nowadays, the shortage of staff results in limitation in clinical learning and heavy workload, which already in my previous speaker, Madam has shown. Then using preceptors, part-time instructors, less one-to-one help for students, consequences for learning and patient safety. So we have a always shortage in the clinical side as well as in the our college setting. Then shortage of experienced faculties. Yes, this is also very much common. Aging, then retiring, increased part-time instructors, clinical staff, national and global problem influence quality education and future nursing staff. Need for increasing educational funding. This is also equally very important to update the knowledge. That increasing space of nursing faculty and nurses, students need more clinical learning, more responsibility for self-directed learning. We also have to teach them how to do the self-directed learning. Increased use of simulation required to validate initial and continuing competency. This is very important. The most of the time we see that students are very much nervous when they go for giving any injection or when they go for doing any catheterization. So if we can have like simulation techniques or some techniques in the practice in the lab before we put them, so it gives them a lot of confidence. Then other issues are innovations in teaching and learning like online programs, use of technology, web-based learning, and computer-assisted learning are being used increasingly to promote intellectual, personal, and career development. Then another issue is that educational quality assurance is a process of monitoring and evaluating efficiency and effectiveness of educational programs. So hospital side, we know that ISO is the NABS accreditation is that, but what we are doing for our this educational side for nursing quality, how do we assure our quality in the nursing institution, educational institution? So this is very, very important issue. As the nursing education is flourishing in the government and private sector in India, there is a need for accreditation of the system and the process. We only get the NOC or the recognition for establishing a college, but thereafter, what standards we are maintaining, there is no criteria to assess us. So this is high time to prepare a quality index of nursing institutions all over the country by categorizing them into different grades based on infrastructure and faculty profile. This is very, very important, having quality assurance in our nursing education. Then nursing education is preparing the students to provide high-tech and high-touch patient care with the help of technology and sophisticated gadgets. We are preparing the nurses for that. Then current trends in nursing education are preparing global nurses who have transitional acceptance. Then nowadays, short-term programs are becoming more popular than regular postgraduate program in nursing. So we know that there are a lot of programs are upcoming. Even nowadays, what we have, the 5 specialties, apart from that, nurse practitioner course has launched. So now students are very much interested to go for that kind of courses. Then they are now also we are going to have NPM program, nurse practitioners and midwives, so they can also opt for that. This is not short course, of course it is 18 months, but other 1 year like anesthesiology nursing, space nursing, then critical care nursing, all these aspects are there. So they are opting for all those. Then there are opportunities for higher education. Nowadays, nurse soon after completion of our basic professional qualification, after 1 year of experience, they can go for their higher education. Then nursing is emerging as specialty. Previously, nursing was considered to be general care, but now it has emerged as specialty nursing to meet the needs of patients in different categories. As Madam has said, they give training on stomach care, breast care. So different modules also, our new CBCS-based system, our new curriculum also, they have given different modules. So nurses are now focusing on the specialized based care, not as generalized care. Government role in promoting higher education in nursing is getting diminished, and private sectors are coming forward to play the dominant role in promotion of nursing education. So government also has to be strong. So private is a partnership always with the government, but government institution where they are running, at least they should have the sufficient faculty members to deliver the quality education to the students. That is the part of government side. Then now there is the need for having qualified nursing personnel in administration and research who can further promote growth of nursing education at in-service education level. So for this, Government of India, they have taken the initiative of opening Directorate of Nursing. So we are also heard about that some of the states, they have already getting permission to set up their own nursing directorate. Even that day I have attended one meeting, and there they have one participants from the Mizoram government. They have said that nursing this budget session is even Mizoram government also, they have approved the opening of their own nursing directorate. Even we are following the West Bengal model. So definitely, if we have our own directorate, we can have better careers and in-service education level for the nurses. Then with this, coming to the end, take-home messages. Nowadays, nursing education is facing various challenges locally and globally. So as well as it is exhibiting multiple facets of reformation. Then from aligning nursing education with the practice setting to incorporating nursing as an integral part of health workforce, and to adequately preparing nursing educators and providing them with proper development opportunities. Then to dealing with technological, economic, and ethnic challenges, then nursing educators are entitled to recognize and deal with the obstacles that come with the 21st century in order to maintain a high quality of nursing graduates, then quality of care as well as safeguard patient safety and satisfaction. With I'm coming to the end of my presentation. with a big thank you. And I just want to show this slide because I am from the land of Assam, which is famous for one horn rhino, tea gardens, and this is our festival. We have Bihu, and these are Bihu dancers. Thank you so much.
Thank you very much, ma'am. Given the narrative information to us, I think the challenges is issues it is told by you regarding that the teamwork, shortness of the faculty, and challenges related to the technology we can overcome for this. I think hope so. If anybody asks any question or queries, to this session is open. This floor for open for the question and queries. If anybody asks you any question or query, doubt. Okay, ma'am. Thank you very much giving the nice information. Okay, thank you.
Okay, thank you so much.
Thank you, ma'am. Thank you so much for your words of wisdom. It will be a great pleasure for us to listen to you again in our future events. Before we move on to the third session, all the participants are requested to fill the post-test and feedback form at the end of the conference to get the certificate. The link will be shared shortly after the session in chat box and WhatsApp group. So let's start our today's third session. The theme is outcome analysis of nursing education and competency-based clinical practices, which will be dealing by Sister Tessie Sebastian ma'am, Director of Nursing, Acharya Vinoba Bhave Rural Hospital, Savangi Mekhe, Wardha. The chairperson for this session is Dr. Alka Azne, Principal, Vibrant Nursing College, Surat. She has completed, Madam has completed her PhD . She has completed her PhD at Malvanchal University. She has 18 years of professional experience in a teaching of nursing settings. She is Secretary General of Nursing Scholar Society. She is member of TNAI, Clinical Nursing Research Society, Nursing Honor Society of India, Nursing Teachers Association of India, Pediatric and Neonatal Nurses Forum India. She presented paper and poster in various conferences. She published articles in various journals. She also awarded as a Best Staff Nurse in the year 1998, Best Teacher in the year 2005, and Best Professor by UIJIR in 2021. So I request Dr. Alka Tazne ma'am to introduce to our esteemed speaker of this session to our audience.
Thank you, madam, with a very nice introduction. First of all, I wanted to thank our both the speaker and College of Nursing, Wardha. We have arranged very nice conference, and we have got lots of knowledge from the speakers. It's my immense pleasure that I want to introduce Dr. Sister Tessie Sebastian. She is the Director of Nursing, Acharya Vinoba Bhave Rural Hospital, Savangi, Wardha. She is having 34 plus years of professional experience in a variety of clinical teaching, research, administration, and management setting. She is a PG and PhD guide. She is a member of TNAI, NRSI, and ISPN. She presented paper and poster in various conferences. She published article in various national and international level. Welcome you, ma'am. What to you, ma'am? Tessie, ma'am?
Yes, I am here. Just a second.
Yeah.
Thank you very much, Dr. Alka, for your nice words.
Many of the things may not be correct, but I accept it. Thank you. But a very good afternoon to one and all attending this conference. Here it is entrusted to me to discuss and talk on outcome analysis of nursing education and competency-based clinical practice. We have heard till now on this topic, the subtopics of this particular topic, many, I think around 4 times, 5 times. And we have heard the depth and width, the height and depth, everything we have heard. And here I would like to talk simple things that we were practicing years together. And how come this outcome analysis for nursing education and that to the end product of that, so outcome analysis, if I would like to give a little definition, outcome is, first time we will talk on outcome. What is this outcome? Each and everything. If we prepare a food, if we go out for a walk, everything we ask for outcome. So here comes also, for our nursing also, we ask for an outcome. What is this outcome? An outcome is defined as a measurable thing. We have to measure at the end of that.
Excuse me, ma'am.
Yes.
Excuse me, ma'am.
Yes, dear.
You can do slides. Look. You can do slides.
Now?
No, actually, we are giving. Yeah. Okay, ma'am. Okay.
Okay, no? Yes.
Yes.
An outcome is defined as a measurable thing. That is for an individual, family, community, setup, behavior, or perception that is measured along a continuum of response to interventions. Whatever interventions we are doing, after that we have an analysis or outcome. We measure it, what it is and how it is. The outcomes are developed for use in all clinical settings and all patient populations. Again, I say that if that is a kind of numerical result we get. Here we get an alphabetical result like that. It is good, it is better, it is best like that. So a result, a new condition or event occurring in individual study subjects which to assess efficacy. That means how much it is efficient or the outcome is how much it is profitable for us or that particular person or whatever we do out of that. The result or visible effect of an event, interventions or process, any changes taken by a person's state, that means nursing is we are doing on a person or a patient or a client of health after a period of treatment. We know that if a patient comes, we take immediately start treatment. Immediately we go for simultaneously along with the medical treatment, we go for our nursing assessment too. So after the assessment, we come in conclusion that this patient is having these many problems. So we started to make our 7 columns of that beautiful nursing care plan along with the assessment. And we write the evaluation column after some time, how that patient came out. Example, like a knee pain, patient came with a knee pain. And medical treatment is given, and along with that nursing treatment, we must have given a change of position or a hot fermentation. After 1 hour, we ask, how do you feel? And from subjective and objective, we assess and we write, patient is becoming better. That means pain is becoming better. So this is the result of visible effect of that particular event. So this is, what is the purpose of this? If we say that outcome or outcome analysis, what's the purpose? There must be some purpose. We know that as a clinical teachers, as a nursing teachers, we all need how much my efficiency or treating that patient in a nursing level aspect, how much it is effective. So the purpose is simply that the effectiveness, how it is. So that is, we use, nowadays it is specifically we use the nursing interventions, and every 6 hours we assess and we reintroduce or we modify the interventions. While nursing interventions are in progress, may be used to modify nursing interventions, correct? Then redirect patient and family participation in the overall treatment and management plan. Re-examine the healthcare team's understanding of the clinical problem. Determine cost benefits or facilitate coping with altered function. These are some of the purposes. As I was reflecting on this, I understood this is a very vague purposes or outcome for the outcome analysis. But of course, this we were doing it the day one of our nursing profession and the day one as the nurses profession is started. So what are the attributes or characteristics of this? What are the characteristics? When we know that when we go to the patient after giving the nursing care, usually we avoid. Why? Because we know it is not going to happen anything to the patient, but still there must be some characteristics of that outcome, patient outcome or patient functional status. So usually immediately patient may not be responded to our call, but still we want to know the characteristics of that outcome, how patient is cooperating with our care. So patient outcomes of patient functional status, that is maintained or improved. Then patient safety, how, what I was, when I was giving that care, suppose usually we can ask this patient safety, what I meant it here, if we give a hot water bath, patient safety. We say according to patient may feel because of pain or any other thing, patient, the first time when we give a hot water bath, patient, oh, it is good, okay, affordable, I can accept or I can bear it, bearable it is the hot. We also left, after half an hour we come back, maybe we find it a readiness over that. So, but patients, the original pain caused by something else must have come down. But here the fact is that patient safe. So the character, when we say the characteristics of that, patient again will complain because patient got maybe slight burn. That's what patient safety, patient satisfaction. How much satisfied that patient after my care? This all together again I put it. Patient's outcome is more simple as the result of the nursing care that was received in the hospital, including maintenance of patient functional status, patient safety, and patient satisfaction. So these are the characteristics, parameters that we look and we do the outcome analysis. If outcome analysis, we say we would like to just go in and just discuss for a minute how this outcome-based education. Nowadays, as we look into the nursing curriculum, nursing process, there must be it's a really twist of wordings or terminologies. Outcome-based education, outcome-based analysis, this and all I said already, it is the day one on was our practice, it included. But outcome-based education, if we say, means it is a student-centered approach. When we go later to the competency-based approach, the same thing will come. Then we may have a little doubt on that. So I started from here itself. Outcome-based education also along with the outcome analysis of nursing. So in a student, it is a student-centered approach of curriculum design and teaching that emphasizes on what learners should know, understand, demonstrate, how to adapt to life beyond formal education. That means simple like this. It's an education which emphasizes individual, very comprehend individual single objectives, and how that student will be able to solve that problem with the skill, understanding, and the capability, everything together. That is it is a student-centered approach to learn that particular event, to apply later in a competency level. So that I will explain later, or we will discuss it later. So this is that. So outcome-based, why I said the student-centered and outcome-based education, I mentioned because of this. So it is sometimes also called a performance-based education. Yesterday, we have heard many classes with this performance-based education. How the students are performing, according to that, the education we see. Yes, this one knows supposed to be 10%. He or she had done 8%, now 2% difference. So on that, how can we overcome that 2% with the skill and efficiency? So that is that here mentioned. The performed-based education is an attempt to measure educational effectiveness based on result rather than an input such as time students spend in class. Simply, as I said, exactly the meaning of that. The student learning outcomes constitute a criteria by which curriculum is developed or designed, instructional materials are selected, teaching methods are adopted, and evaluation is conducted. Very simple that. So I just want to mention it, this curriculum-based and or outcome-based education also. That means outcome analysis combining with outcome education. So I mentioned it. That the core principle, these are we know exactly. I just revised it. Why? When we see the outcome-based education, clarity of focus on culminating outcome significance, clarity. We say, how much clear that student regarding the process or the thing or a procedure that child does, that clarity focus. That is the first thing. Expanded opportunity and support for learning success. Expanded opportunity. That means many alternative we can use for attaining the skill. Suppose that child has to get or that student has to get. Then high expectations for all to succeed. High expectation, that means skill, knowledge, all those things. Then design down from your ultimate culminating outcome. So we know, then we synthesis is that this much outcomes I got out of this study. So these are the 4 pillars or 4 power principles of this outcome-based education. 3 types of competency also in that outcome. That's what I said, outcome-based education is going to the competency-based education. So here that is that 3 types of competencies that student will get it, or that nurse student will get it during this outcome-based education. That is, we all know that practical, fundamental, reflective. This is the terminology, and we know that knowing how to do the things, what to do the things, and at last the synthesis, they put it together and reflective way, how can we do it in the practical level. That's all we are doing it in this outcome based learning or education. The benefit also are the same as clarity, flexibility, comparison, because this, when we do it in a student, we first and foremost, we said it's a student-centered. Otherwise, also we know nursing is as a student-centered. It is nursing education is a student-centered. That education, they will go and practice as a patient-centered one. So it goes like that. So it is a chain line. So when they do it as a benefit of outcome-based education, there must be clarity, must be there, flexibility. That means they can learn not only exact in the classrooms, there is exact in the simulation lab. No, flexibility. Wherever they get the opportunity, they learn, but they learn at a time one. Then comparison. They compare the things with this, that, and they know the differences. That the ability, skill. Then the involvement, all these things together to have their practical aspect. And as we talk on Sorry for the interruption. So I have just put it here, this Bloom's taxonomy, because nowadays we are very familiar with this Bloom's taxonomy. Whatever, whenever, wherever we teach something, we learn something, we take this particular name, Bloom's taxonomy. So outcome education also exactly in the knowledge level assessment, exactly all these 6 parameters we are getting. I'm not going into that to explain much, because we know that knowledge level, how they are getting the ability to remember the Vyas, what are the things taught them previously along with that. Then we comprehend the things. Then application is, it is an ability to use learned things, how to apply it. Analysis is analyze it, synthesis it, and evaluation after that. I am not going to explain much. I want to just mention that these are all things going through our education, and this analysis we are doing the day one, and that also is parallelly or simultaneously in our profession, in our education, it is going on. Now comes, so first part is competency, outcome analysis and outcome-based education, all regarding our nursing education. And then the second part of that, the continuum of the topic, competence. We, as a teachers, we speak, at least as a nursing teachers, we speak per day this competence word at least 10 to 50 times. Another thing, competency, another word, that also we speak. And competent, that word also speak. So these 3 synonyms, these 3 words are coming in our practical or the practice, nursing practice or clinical practice. So what is that? What do you mean by competence? So we say that competency-based clinical practice. So what is, before that, what is this competence? The competence, the ability of a nurse to demonstrate the knowledge, skill, judgment, and attitude required to perform activities within the defined scope of practice at an acceptable level of proficiency. Then competency-based learning means what? Competency-based learning, that only we are giving every day to our students, is an outcome-based approach. Here comes exact what I used before. An outcome-based approach to education to ensure proficiency in learning by students through demonstration of knowledge, skills, values, attitudes required for dealing with real life situations at the age or grade appropriate level. Then competency, the necessary knowledge, skill, and attitudes a nurse must possess in order to perform a set of defined activities to an expected standard. So here I would like to say an example. See, we all are when we analyze our students or when we evaluate the outcome of our students, we say, oh, that student is very competent, or that nurse is very competent, or their competency is unimaginable. All those articles we use, or along with this person's propositions. But what is? So if I say one example regarding this, if we are at administrative purpose or we are on the round and or we see different nurses and different times they give different medications or different procedures they do, nursing procedures. So suppose excellent student, that means knowledge base 100%. And other things, attitudes, and nurse, that all things may not be that much, but we are knowing that student or that nurse is with knowledge. So knowledge, skill, attitudes, everything will be in the competency based. We have seen that competency means the necessary knowledge, skills, and attitudes a nurse must possess in order to perform a set of defined activities. Suppose giving IM injections. This particular knowledgeable nurse came and just asked the patient, you are at 6 o'clock time in the evening, 6 o'clock time for your injection. Yes, nurse came, upper outer quadrant, exact she knows, just gave in the injections. Patients So now comes how it is. Knowledge is there, 100%. No problem comes or no problem comes patient, no problem comes her or anybody, because accurately where is supposed to give, she had given the injection, and the patient now the outcome is like that. How the patient, feelings of the patient. She introduced, it is told, you have to inform the patient. She informed, the 6 o'clock time is at 6 o'clock, you have to get your IM injections. The privacy of the patient, the feeling of the patient, the emotional situation of the patient, this and all we have, that particular nurse must have forgotten. She knows where to give injection. She was very much accurately and very much thorough with that. Oh, IM injection, this much is the injection is prescribed. Yes, she had taken it exactly, and she knows that upper outer quadrant finish. So this competency, but she has that ability, skill, everything that to give. She knows it, but the only one parameter is very high, that is the knowledge. So then comes what is this competent? Being able to demonstrate the necessary ability, knowledge, skill, and attitude across the domains of competencies at the standard that is determined to be appropriate for that level at which a nurse is being assessed. Competent. We always say, she is competent, he is not competent, or he is competent or she is not competent. So what is these 3 words played here? Competent, competency, and competence. Competent for the competency-based care in a competency manner. Competence with competence. Competent for a competency-based care. Yes, she is competent for the competency-based care in a competence. With competence, otherwise, with competence. Then what is this? I simply explain these are these things because some potential ability. What is this competence in other way? Potential abilities that may work effectively under certain circumstances. Motivation to show one's usefulness using those abilities. On the other hand, competency is a behavioral characteristics that is based on one's interest and experiences influenced by his or her motivation and attitude. And it is an optimal behavioral trait that likely leads to achievement. So usually in our education, usually with our evaluation of a person as a nurse, we forget the last part of that, that is behavioral trait. Different trait, we all know that in psychology, we learn different traits of personalities. So this trait, that is very much important here. I think that first example I said about that nurse also, everything, 100% it's knowledgeable and is courageous, and the patient will know he can buts for that to apply that injection or to give that injection, but this other things are, other parameters are hidden. Maybe that is the part of the personal trait or behavioral trait. So here, competency-based practice. Nursing competency has the ability to take action, combining knowledge. It's a combining competency, means a combining knowledge along with what? Skills, values, beliefs, and experience acquired as a nurse. Not only knowledge, along with knowledge is the prime thing. Knowledge, skills, values, beliefs, and experience acquired as a nurse. And explain the competency can be viewed as an integrated performance. Integrated performance. Now we are having another parameters for learning, integrated education, integrated nursing education, integrated nursing practices. We have had a 6-7 years before, 7-8 years before, integrated education. I mean, the beginning of that, it was really a panicky for us, integrated. Once one topic, once we teach, is suppose the anatomy of muscles. Then we have to call the anatomy physiology teachers. Then we have to call the teacher one who is teaching the muscles and other things in medical surgical. So all people will come, all teachers will come together and they will explain what is this muscles or what is this, and that is integration of everything. That means knowledge. Then how do we explain it? How do we practice it? How do we use this knowledge in the clinical setup, and how it is? All those things, that is integrated. That one topic to teach, we at least take 3 hours. That means it is well versed. That student or students will be well versed. That knowledge level, definitely anatomy and physiology by hearted regarding the muscles. Then comes medical surgery. What are the things happen to that muscles? If individual pain, individual twist, individual harm happen to those muscles and different muscles, what are the care we give, how it is, and the curing methods, medications and pharmacology people. I said, no, it's a line of teachers are coming and teaching integrated performance or integrated nursing education. Now also it is going on. So integrated performance reflecting the professional nurses' feelings, thoughts, and judgment. So all these things we teach them, but the last 3 parts, that means feelings, thoughts, and judgment, it is only and only as subjective feelings. Only a person as a nurse who is doing that, who is learning as a nurse, who is going to implement, that person is a feeling, thoughts, and judgment. That is simply and only individual feelings, or it is subjective. We cannot, we always say, no, encourage the persons or motivate the persons. I have a doubt here. These such kind of things, personal traits include all these things. So that is individual performance or individual feelings, or it is very, very subjective. So the ability to take action, combining knowledge, skill, values, beliefs, and experience, all those things perfect. All these things, a nurse will go and practice or give care in the clinical setup. And definitely, there also we need evaluation or analysis, because these certain things are not common. It is very individual, personal feelings or subjective feelings. Nursing competency, again, I say, as a holistic integrated concept, which is constructed from complex activities. We said, what are the complex activities? Knowledge, skill, performance, everything. So many activities are coming. So nursing competency is a holistic and integrated concept that now all of us understood. So what is this holistic? What is this integrated? That means simply that we always say, no, if one patient is come with a headache, so we always say, what happened? We ask the patient, so it's a headache. Okay. That patient must be having some psychological problems, stress, or other problems, or neurological problems, maybe having some type of physiological problems, anatomical problems, many other problems, but we only hear headache. So we nurses, we have in our curriculum teachers or as a holistic approach, So integrated concept, which is constructed from complex activities. So here I would like to say that why I have said the earlier, outcome nursing education, outcome-based nursing education. So outcome-based nursing education, I said it is a very specific student-centered learning, very specific student-centered learning. At a time, one at a time. We teach them one procedure at a time, one procedure, one step at a time. So it is very specific learning method. But here, all those specific ones, put it together and comes as a holistic approach when they practice. That is simply, we call it as a competency-based clinical practice. So that is the difference between the education, outcome-based education or outcome-based learning, and competency-based education and competency-based practice. So individual or kind of very simple, singular, student-centered learning goes at last in the analysis, synthesis, when they practice it with alternatives, that will become a holistic one. Holistic one means more than one. We see there, physical, psychological, anatomic, all those four aspects integrated, and we take care and we do it. So it's defined as a performance competency, which means the standard accepted from potential competencies that we have included in that explanation. So this is the difference between, once we learn, yesterday some of the deliberations I have just heard that what we are learning, the same way we will be able to practice. So there is exactly that person may be explained. We suppose an example. If you want to take a temperature, we teach them how to take a temperature. We prepare it first and foremost. We prepare a sophisticated tray, contains a thermometer with this hot and soft, all those things. There are so many things. So complete tray we prepare, and we teach the students in the simulation labs, and we send to the ward. So ward, there must be suppose a 30 patients ward having one thermometer and all those things. So student will prepare a sophisticated tray. Then the in-charge will say, "Are Baba, where are you going with this? This is only one thermometer and one thing. So you have to take here like this." So she will show her versions, or without harm, what the practicing in the wards, they will take it. So this is what is said, the exactly different aspects. That means what we are. So student will be having a confusion that, "Arey, we have learned like this. Oh, this much, this also we can do it, no problem." So this is, we are diluting. It's another word we can say as a diluting. I am not saying about the diluted method of practices. I said as we are learning it individually, and when we practice this, all those individual learnings are putting it into one thing, one box. That is what a holistic approach as we practice. Then clinical competence. Clinical competence is the ability to provide safe care in a manner that views a larger perspective of the patient, and an ability to accurately assess and critically think through the best options for using evidence-based. So we say evidence-based. So till now we were talking about this practice, that is competency-based practice is ability to provide safe care in a manner that is with the skill, knowledge, understanding. It's kind of holistic approach we see. But in the clinical, when we do it, a little more critical thinking that is comes as is we can, there comes our research and the knowledge domain again. Because example, along with this, halfway I stop and I'll say an example. Years before, when I was a student of nursing, yes, that means around 35 years before, 37 years before, we come to the surgical ward. If it is an amputation, surgical ward, we know that, yes, there is an amputation today. So we have to prepare the bed. And we usually carry that sandbags, heavy sandbags, 2 sandbags on the bed, and we prepare the surgical bed for that patient. After that, after completing my studies and doing some work, and after that, 10 years after that, no sandbags. Instead of that, we are using something else. Because we found out sandbags, just sandbags, we may change the cover of that sandbags and put it on the bed, and for the support of this amputated leg. So definitely there will be there will be infections, can cause infections. So I don't think only human beings are transporting fast and faster with supersonic vehicles. These microorganisms are also started to walk very fast. So we found out that nurse only found out that yes, there can be infection, more infections if we use like this sandbags. So the same way, abdominal binders, any open surgery, I mean abdominal surgeries, we always give them abdominal binder. That is simple with the cotton abdominal binder. washed and we send to the CSST for disinfection and bring it and we give. There also we found. See, these are some of the, that is evidence-based practice. I just want to explain that evidence-based, that is nurses are not that just they are thinking all this, and competency means included evidence-based practice also. How it is happened, why it is happened, we have to think always, and for the betterment we work. That is, there comes the evidence-based practice. So clinically competent professional nurses are capable of evaluation of the level of patient awareness, observe indirect influences in the patient situation, effectively transfer this, provide the appropriate treatment and care with sympathy and comprehension. So we said these are studies with sympathy and comprehension. Comprehend manner. We are not going to give it as an analytical manner. We give it as a comprehended manner. So this also I just revising. I already we have said this the outcome of this. So this competency-based education and learning, it has got certain elements, components and elements. So we know that we are practicing this. I simply put it that we know that the ability to understand the people. I said that earlier. I said individual client come to us or individual client, we are going to them. We must understand how they are and what they are and what happened to them, and all those things are history as such we learn, and then let's understand the people. The ability to provide people-centered care. The ability to provide people-centered care. Note that what we have, yes, we have heard there's a pain. What is that? Is fallen down and knee is paining. So we say knee paining. We give position and we give, we have just learned in our nursing art, if wherever there is pain, either change the position and give otherwise some hot water bags. So ability to provide people-centered care. Maybe that person must have fractured. We don't know. So that ability, how and when and where. Ability to provide people-centered care or client-centered care. As we give education to student-centered. Here after learning, they come and give, or we provide the care as a client-centered or patient-centered, or in general we say people-centered care. And the ability to improve nursing quality. So individual, at times we may have, that time such cases I gave, this care was there according to Nanda. Nanda means sometimes now the new once this Nanda nursing care is a very, very famous. I think from around 1984 onwards, I am hearing this Nanda nursing care, Nanda nursing care model and all. So now also when we take practice of this, Nanda means first and foremost, this recent ones we asked the student. So only one student was there. I said, where is your Nanda? Where is your Nanda nursing care? What is that problems? Then that student looked at me once again. Madam, sorry, I am Vagmare, not Nanda. So the attitude of that students, you know, that means they are nursing care means it is third-year student and asking such things, and they will also, because they are not acquainted with this kind of nursing care and model and what are the problems and all. This is based on what I think from first year till they go out, it is a continuous process to tell continuously. It is like us without remote we say, no, continuously inform them and see. So the ability to improve nursing quality means once we do the care, twice we have given the same type of patients care, and there is the differences I may be able to see, or the differences I may be able to understand. Then the third one I give, oh, these two patients were like that. So same thing will not be. So let me try. So maybe have an inhibition in the nurse's mind that 2 times I have given the same care and there was some block. It was not. And the analysis I found out these and these are the lacunas. So keep it in mind and immediately we can, if you apply, we can find out, yes, and improve the nursing care, with that, the satisfaction of the patient, and with that, lessen the hospital days. So many things are there, ability to improve nursing care means. Then elements. We all know that now many times I have said it in our discussions. What are the elements? That means how a competency-based nursing care means what are the things? Again, applying knowledge, interpersonal relationship. That means we must understand our own as a nurse. In psychiatric nurse, we say the principles of psychiatric nurse, we say individual nurse must understand their emotional status. There is a principle is there. The same way here, building intrapersonal relationship. That means within ourselves, we must have an understanding of in a person as a nurse. What are the relationship? How are you? Maybe patient will be like that, like me. Examples. First and foremost, we take the examples from within and we will percolate to others and have a relationship. Then providing nursing care. Practicing ethically. As I said that injection, yes, upper outer quadrant perfectly, but how to ask permission to remove the cloth or asking for privacy, all those things. That's what ethic or ethics in nursing we teach the first year and we always forget certain things. Then practicing, collaborating with the other professionals. We know that it's a collaborative teamwork, we say, medical team or nursing team work, we say. So usually we say, who all are in that team? All A to Z, all people we have taught them and we have learned also. Expanding their professional capacities. Expanding their professional capacity. In these professional capacities that are coming, evidence-based practice, nursing research, all those things, that's what we are putting it and trying to improve the professional capacities, ensuring the delivery of high quality nursing. That means we have lacunae, then we understand, again we learn, again we practice. Core competencies, we know 101% we are sure of that. What are the core competencies when we practice competency-based practice or competency-based nursing? Patient-centered care, teamwork or collaboration, evidence-based practice, I said, critical thinking skills, quality improvement, leadership skills, teaching skills, informatics. So these are the core competencies. Now it comes at 11 core competencies, 12 competencies, because it can divide and we can make it. So individual level, each competency in this level, it will be levels of that competencies, following basic nursing care procedures and practicing nursing with needed advice, practicing nursing independently based on standard nursing care plan, practicing individual nursing suited to care recipients, practicing nursing using predictive judgment with a broad perspective. In more complex situations, practicing nursing by selecting the best means of care recipient and increasing quality of life. So these are individual core competencies what we have seen. This is the level of individual we take, all these 5 will be applicable. Then I have just taken, we have, if I said BSc nursing or general nursing, now curriculums are revised and almost, I think we have in BSc we have 43, individually we are counting 43 subjects we are teaching within the 4 years. 43. If general nursing means almost, it is like, I think 37 I have counted. I'm mistaken. If I'm not mistaken, 37. That means this research, then management we have divided. I mean, I think any profession, people will be taught this many subjects, I don't know. But we learn purposefully and we teach purposefully. That is the beauty of our curriculum. So here I have just put it that at the end of the first year, so the students shall have acquired an understanding and awareness themselves as an individual and as a member of the family, the community and the world, with emphasis on personal, societal and professional values, responsibilities, rights and awareness of physical, social and cultural milieu. That means we ask the first and foremost, the first year we teach them how to take a history of the patient. So all these things what I have said is coming under that. And along with that, infection, psychology, we are teaching this anatomy, physiology, all these little, even, all these things. So with that, they understand a person, how it is. How can a person become sick? And if become sick means what are the changes comes? How we can bring the person into their safe status. All those things we are learning in the first year. And if we take the second year, the students shall have required the holistic understanding of the human person as bio-psycho-cultural being, focusing on the concept of health and illness, and it is related to the care of mother-child in varied setting, whatever it is. At the end of the second year, what a student will learn? Understanding of the human person as bio-psycho-cultural being. That means people are living in this world, bio-psycho-cultural being. That means culture, the biology and psychology, and all these things, and in that situation, the environment where we live, all these, along with that, what are the changes can come, what are the sicknesses we is prone to get, all those things they are learning at the end of the second year. And the end of the third year and fourth year, that means the maximum. The student shall be able to demonstrate the competencies, what they have learned in the following key areas of responsibility, such as safe and quality nursing care, communication, collaboration, teamwork, health education, legal responsibility, ethic, moral responsibility, personal and professional development, quality improvement, research and management of resources. So all those things, they are third and fourth year, I said, because general nursing also and fourth year BSc, so I put it together. But all those things, the step by steps we are learning, step by step. We are not putting all those things according to their age, according to their capacity, according to their differences in their able to differences, accordingly we are teaching them. So to acquire nursing competency, a nurse must possess the skill and personality necessary to effectively perform their duties. So this is a specific contest I put. And the competencies based on all those things we can see, because I have mentioned earlier also, personal trait is one of the important things, because personal traits are particularly for subjective matter. So personal traits necessary for nursing, including affection, understanding, control, critical thinking, and problem solving ability. This and all, we can simply understand that these are the things. So that's what we say: individual person, unique. People are unique, we say. So our students are unique. So this, to remember and revise, I just put it. Then professional attitudes and behaviors. The ability to provide care based on professional knowledge and skill. So these are some of the specific contests when we speak on competency-based care. So after all, what are the importance of these competencies in nursing? Best knowledge can do their job more efficiently. It will influence the well-being of patient, improve the provision of medical care, also satisfy nurses with their work, improve nursing education and clinical nursing, ensure right people throughout your clinical workforce are equipped to achieve optimum performance outcome. Optimum performance outcome. Enhance the expectations of the patient and improve patient satisfaction. These are some of the importance of this competency-based nursing. That means we know according to the knowledge, best knowledge can their job more efficiently. That's what we are putting all these. I said, 43 subjects. So I here this model, I don't know how much it is comprehend here. I just put it that because 2009 and 11 repeatedly this model came for us. We were talking only about the competency based, this terminology. Competency based nursing care, the day one onwards we were practicing, but this terminology we were started to use from 2009 and 9 onwards. So these people find it out that competency, outcome, and performance assessment. So there's a model for COPA model. So the effective role performance in the workplace by delineating comprehensive core clinical behaviors that provide evidence of competence. So perfectly, accurately to give this nursing care or perform the nursing care at workplace, they use this model of that. So nursing education is influenced by the COPPA model by the use of coordinating curriculum framework that promotes competence for practice. It is, we all have, in the nursing, precisely we take some models and theories for our nursing nursing practice and nursing competency-based practice also. So this is also very effective, I feel, because it made us easy our work, how to teach the students and how to practice this competency-based practice in the clinicals. So the 4 pillars again came, this method also, or this method again saying, this model is again saying what is core practice competencies, that is 8 what I have said. Competency outcome, we are again, here again come outcome, competency. I have done with my competencies, but there will be outcome and there will be an analysis too. So interactive practice focused on learning, interactive practices. Competency, performance, examination, and assessment. So we can have our, that's what outcome analysis we do with the different evaluation formats. So these are some of the pillars that they say. Then outcome, if we say numerically and alphabetically, if this is the outcome of competency-based nursing or based for nurses, outcome, what are they? Patients are more satisfied when they perceive their care came from well-qualified and competent staff. Yes, if they understand, that means they are not in a panic. Otherwise, the patient, we know that we also, maybe at times we were sick and we know how much anxiety individual we have. So how must be that nurse or how must be that doctor or how we will be treated in the clinicals, all those things, you know. So once we know, oh, this, if I am, since I am working in a rural area, I can immediately understand. The patient immediately will find out, oh, that day where were you? Because I was searching for you. Because you know that as they see the person itself, their anxiety is gone. That's what patients are more satisfied. Then clinical outcomes and patient health are improved. That is definitely. Competency-based management can promote nurses' enthusiasm and reduce job burnout. Nowadays, that is what usually say that US nurses say that burnout. They nobody want to become a nurse. That because they say it is very tedious job like. So reduce job burnout, improve job satisfaction because we know the knowledge, we know the skill, we know how to perform. But still there is a hurdle for us, that is a less personal, but still we manage. Increase his or her knowledge and skill on an ongoing basis. This beyond meeting the minimum requirements for licensure. That is increase his or her knowledge and skill on ongoing basis. So how can we maintain? How can we maintain our competence? Or that's what we are having now. This is one of the point there we can maintain our, that is simple, these kinds of conferences. You can maintain and enhance your competency through education, professional organizations, networking and conferences, webinars and continuing nursing education, modules, certifications. So all these things encourage the nurses and they will be more competence and they will be improved in their knowledge and skill regarding the particular nursing process and procedures and skills. So here all about, we have just talked a wide of in outcome analysis, outcome-based nursing. Then we started off competency-based nursing and difference in competency and competency-based, all those things and how they affects outcome. So as a whole, if I would like to conclude my topic in that way. See, all these things we were practicing day one onwards. But what happened? The terminology we use and put it in a practice, it may become, it was not a systematic way. Yesterday that Dr. Sami was talking. Dr. Sanjay was talking on scenario-based practice, scenario-based practice. My dear friends, if I talk on the scenario-based, it is a terminology, I would say, because our nursing practices started from the first, as we say, clinical practice, clinical presentation. So what is case presentation in the clinicals? What is that? We are taking a scenario. But it is very nice. We are, that is our research. What is that our professionalism is improving, and professionalism is in a research way. It is more, revising and put it in a systematic way. So scenario based, it is very nice, a terminology, scenario based, instead of that clinical practice or clinical performance or a kind of clinical case presentation, instead of that. So as a whole, when we say it's a mix of skills, knowledge, attitude, and abilities that each nurse must put it together and perform acceptably those duties directly related to patient care in a specific clinical context and given circumstances in order to promote, maintain, and restore the health of the patient. So a mix of skills and knowledge, it's that ability to mix all these things, I would say. And that same thing what we have learned, mixing up together, that is synthesizing and putting it into practice. For what? Restoring the health of the patient. And same way, integrating knowledge and skills. Integrating, I said about the integration. Integrating knowledge and skills, clinical setting in a feature of nursing competency. That means it's a holistic approach. It's a holistic approach. We learn individually or precisely or particularly, and we put it into holistic way. So competency is associated with core ability to provide care based on the needs of the person who is receiving the care is called a practice. And above all, as we say, the difference between competencies and outcomes can highlighted in the words outcomes and competencies. So what is competencies? Need. We say no, need-based care. Need-based care. First and foremost, we say the students prioritize the needs of it. So need-based. Competencies means need, and this outcome means, what is that? It's kind of, so outcome defined as skill and qualities we want student to have, whereas the competencies is defined as a skill and qualities we need healthcare for professionals to have a care of patients safely and effectively. So it is because we want and we need. So this together comes, this want and need comes, the competency is holistic. So as I say, I want to conclude with these words. Let us never consider ourselves finished nurses. We must be learning all of our lives. It is said by Florence Nightingale. Thank you, thank you, thank you.
Thank you so much, ma'am, that you are enlightened us with the elaborately you told outcome of nursing education. And we are very happy to hear you, ma'am, because you know, when you are conducting your session, I think those who are senior one here and those who are, I must say, in my age, we used to remember our those days when we were in a GNM program or a BSc program, and we were practicing all those things. So thank you so much, ma'am. You have taken us in that era. Thank you so much. If you wanted to ask any question, you can ask madam, participant. If you have any doubt, you can ask to madam.
Thank you, ma'am. Thank you for sharing your deep knowledge with us. It's really enhanced the knowledge and motivate to implement in the nursing care. Now, I invite Dr. Alka Tasne, ma'am, Secretary of NSS, to enlighten the gathering.
Thank you so much, madam. First of all, I thanks to SRMM College of Nursing, Wardha, that you have organized this wonderful conference. And I have seen a huge participants since 2 days. Everyone got a deep knowledge, and maybe they will use in their practice. And I want to thanks to Dr. Ranjana madam and her team, and Dr. Seema Singh madam.
मैम आपकी आवाज नहीं आ रही मैम अनम्यूट करो मैम आप
Can you hear me?
Yes, ma'am.
Okay. So I want to congratulate again to SRMM College of Nursing, Wardha. And I just want to say about our NSS. So NSS is a Nursing Scholar Society, which is last year only it is formed. And our patron is Dr. Swaresh Khanna madam. She is in USA, New Jersey. So Nursing Scholar Society, when we formed last year, our madam's slogan is that care to caregiver. So we there are lots of activities also we are doing, but the most of thing is what those who are working in a nursing area and teaching area, we can say a service side and teaching side. So we are caring to that person, and we are taking these type of the legendary nursing peoples in our nursing profession. We are taking them, we are appreciating them, and we are felicitating them. So it is it's getting a motivation for all the people those who are working in a nursing. So it's not our motive to bring the person for activities, but also we wanted to give so many things what we wanted to give. So this is Binu sir. He will be a doctor soon, and our secretary general is me, and Dr. Sudha Singh is a chief editor in a Nursing Scholar Society. Then Anu madam is there, she's a treasurer. So all we are working, and we are timely we are conducting the meeting. What we have to do? What we have to do for enhance the nursing profession? There are new activities we are planning and we are doing, and what this conference you are attending, the same thing we have talked with the Ranjana madam, and this conference was organized. So thank you so much to inviting us and collaborating with us in a Nursing Scholar Society. Thank you again, once again.
Thank you, ma'am. Thank you so much. Thank you, ma'am. Thank you so much for your word is very valuable for us, and we are motivated in our future conference and CLE. Thank you. Now it's time of declaration of result, scientific paper presentation. I would like to invite Professor Sudha Singh madam to declare result of scientific paper presentation.
Good morning to all of you. This is Dr. Sudha Singh Mohe. I'm going to announce the results of the scientific paper presentation, which was held yesterday. In first position, The first position is gained by Deepika Ta. Her problem statement is an experimentary study to assess the factors contributing to maternal childbirth satisfaction with delivery services among mothers at selected hospital in Mohali, Punjab. Congratulations, Deepika. Second prize gained by Jamai Fatima Hashmi, and her problem statement is a cross-sectional study to assess the psychological impact of COVID-19 pandemic on nursing students in selected Nursing College of New Delhi. Congratulations. And the third prize goes to Monica Gangoda. And her statement is a study to assess the effectiveness of structured teaching program on knowledge regarding the Janani Suraksha Yojana among the antenatal mothers attending MCH clinic at selected community health center, Surat, Gujarat. Congratulations to all the winners of the scientific paper presentation. And I'm going to giving heartily thanks for providing me opportunity as a judge for judging the scientific session. Thank you so much.
Thank you. Thank you so much, ma'am. Congratulations to all winners and participants. Now, it's time for e-poster presentation. First, I introduced our judge. Our first judge is Dr. Rahul Pandit, nursing officer at BJGMC. He is having 14-year experience. In the clinical and teaching area. He has published 16 articles in national and international index journal. He has presented paper and poster in various conferences. He awarded as a best bedside nurse by BJGMC, best nursing teacher by NTAI, and young researcher award by INSC. Then our next judge is Miss Shweta Sindhu, assistant professor, Government Nursing College, Rajnandagaon. She having 14-year experience in teaching area. She has selected in PSC exam in government sector in the year of 2016. She is master trainer in tuberculosis program and master trainer in community health officer in Chhattisgarh. She also state mentor in CHO. Now, I invite Ms. Ashwini Khope, Madam, our observer, Vice Principal, Srimati Subhadra K. Jandal College of Nursing, Pune, to declare result of for interruption. Now it's time to declare the poster presentation result. I invite Dr. Rahul Pandit sir to declare result of each poster presentation.
Good afternoon, everyone. Thank you so much. All the respected administrative officers of DMMS, respected Veda sir, respected Borle sir, then respected principal Seema Madam, respected TC Madam, Paksande Madam, Gave Madam, and the coordinator of this national conference, Ranjana Madam, and all respected teachers of DMMS College of Nursing, and all dear participants. First of all, I thank you so much for having me here in this national conference and inviting me as an evaluator for this poster presentation. Before announcing the result, I feel very proud. Please accept my sincere congratulate for an organizing such a successful, wonderful national conference on this integration of nursing education and nursing practices, that is the competency-based clinical practices. And this is a need, this is an important in present era. There is a need, yesterday respected Mishra sir told there is a need to do the evidence-based practices. There are so many literatures, there are so many books, there are so many researches are available, but there is a need to implement that results, that finding, the reliable, valid findings into the nursing practices, into the clinical practices. Then only we can upgrade the nursing profession. It will help the future nursing direction. So really, this conference was very well organized, and I congratulate all organizing team members, and really it's very well organized in terms of content. First of all, I feel very proud to be an alumni of this institute, that is the Srimati Radhikbai Meghe Memorial. I was the first batch students of this college, and I feel very proud that this organizing committee have given me opportunity and provide me this platform for this. When I think about this institute, really that days were unforgettable. I proudly feel that days I get infinite love and lessons from my respected teachers, Gawai Madam, especially thanks to Tesi Madam, then Seema Madam, Ranjana Madam, Paksande Madam, Maurya Madam, all respected teachers who taught me. Because of their guidance, their lessons, I can stand a successful person in this era, in presently. So those teach me to do this hard work for the success and clarify my vision for the future. So this, I am very grateful to this institute, this SRMM College of Nursing for providing me guideline and motivation and to inspire me to achieve the goal. So because of all respected teachers, they taught me administration, so I can publish my nursing administration and management book. So they have motivated me, they inspire me, always they are instilling the motivation and inspiration to me, yes, to do the best, to get the achieve the goal, to get the success. So thank you all respected teachers. So I look forward to meeting you soon and again. So here I announce the result of this poster presentation of this national conference. For this national conference poster presentation, respected Sweta Madam was there as an evaluator. So both evaluation, then as and for this management decision, the third best poster presentation will be is for Priyanka Kavaluru, is the third prize for the poster making competition. Then the second best poster presentation is for Miss Ashwini Chauke, and the first best poster presentation is for Princey Saji. So these are the three names. The first is Princey Saji, the second is Ashwini Chauke, and third one is Priyanka Kauluru. So congratulate all best scientific presentation poster presentation winner, and thank you so much. Thank you.
Thank you, sir, and thank you, ma'am. Congratulations to all winners and participants. Now, I invite Ashwini Kope Madam, Vice Principal, Deccan Education Society, Srimati Subhadra K. Jandal, College of Nursing, Pune, I invite you, ma'am, to enlighten the gathering.
Good afternoon. Am I audible?
Yes, ma'am.
So, good afternoon, Dr. Rajiv Borse, Dr. Wagmare, Dr. Gevre, Dr. Seema Singh, Madam Principal, Professor Vaishali Tatsande, Madam Vice Principal, the members of the Nurses Scholar Society, all the advisory committee members, all speakers, and dear participants. First and foremost, I would like to thank the organizers for giving me an opportunity to speak at this occasion. I would like to congratulate the entire team of Srimati Radhikabai Meghe Memorial College of Nursing, Savangi, for successful completion of this national virtual conference. I further congratulate the members of the organizing committee who have worked under the efficient guidance of Mrs. Ranjana Kumar, the organizing secretary of this conference. I appreciate the team for approaching the very eminent speakers for all the sessions who had extensive knowledge and expertise in their respective fields and who shared their knowledge with their participants. I'm sure that the sessions will enhance their knowledge on the topic selected, that is integration of nursing education and competency-based clinical practices. I further especially thank all the winners and runner-ups of the scientific research presentation and the e-poster presentation, and also all the participants of this scientific research presentation and the poster presentation. So as the observer appointed by the Maharashtra Nursing Council, Mumbai, I feel it as like my proud privilege to be an observer of this virtual conference, national virtual conference. I found that the conference was very well organized and the topic that was selected was actually the need of the hour. Once again, I congratulate the entire team who have strived hard to make this conference a success. Thank you.
Thank you, ma'am. Thank you so much for your valuable words. Now, it's time to give feedback. Anyone want to share their views about the conference? Please share with us. Now, if you anybody want to share something about the conference, please share. Please share your views. Now, I would like to request Miss Ranjana Sharma, Professor, Medical Surgical Nursing Department, Srimati Radhikabai Meghe Memorial College of Nursing, to propose the vote of thanks.
Thank you, Priyanka Madam. Good afternoon to all the dignitaries, respected teachers, my dear colleagues and participants. On behalf of Srimati Radhikabai Meghe Memorial College of Nursing, Savangi Meghe, on my own behalf, extend a very heartfelt thanks and gratitude to all dignitaries of the National Conference. The entire onset, we would like to express our gratitude to our management who always support us in all our activities. Honorable Shri Dattaji Meghe Sir, Chancellor, DMIMSDU, Honorable Shri Sagarji Meghe Sir, Member, Board of Management, Honorable Shri Sagarji Meghe, Samirji Meghe Sir, Member, Board of Management. Thank you, sir. We express our sincere thanks to our mentors and policy makers. Honorable Dr. Ved Prakash Mishra Sir, Pro Chancellor and Chief Advisor of DMIMSDU, Honorable Dr. Rajiv Borle, Vice Chancellor of DMIMSDU, Honorable Dr. Lalit Wagmare Sir, Pro Vice Chancellor of DMIMSDU, and Dr. Babaji Ghevde Sir, Registrar, DMIMSDU. Thank you, sir. I would like to express my sincere thanks towards our National Conference speakers and the chairperson, Dr. Seema Singh, Principal, SRMM College of Nursing,
Dr. Sanjay M. Pirapurkar, Sir, KLE Society Institute of Nursing Sciences, Hubli. Dr. Shobha Gaikwad, Madam, Assistant Professor, LT College of Nursing, Mumbai. Dr. Vasla Sadan, Dean College of Nursing, Christian Medical College, Vellore. Dr. Lukima Sekia, Lecturer, Regional College of Nursing, Government, Assam. Sister Tessie Sebastian, Director of Nursing, Acharya Vinoba Bhave, Rural Hospital, Savangi Medye, Wardha. Thank you, Sir and Madam. I extend my sincere thanks to Chairperson of this conference, Mrs. Indu Alvatkar, Principal, School of Nursing, Savangi Medye, Wardha. Dr. Muhammad Hussain, Vice Principal at Gokhale Medical Society, Nasik. Professor Vaisali Taksande, Vice Principal, SRMMCON, Savangi Meghewardha. Professor Jaya Gavai, Madam, Dean Academics. Professor Archana Maurya, Madam, Professor in a Child Health Department from SRMM College of Nursing. And Dr. Alka Tajne, Madam, Principal, Vibrant Nursing College, Surat. I extend my sincere thanks to observer of the 2 days CNE appointed from the Maharashtra Nursing Council, Dr. Ashwini Khope, Madam, Vice Principal, Deccan Education Society, Srimati Subhadra K. Jindal, College of Nursing, Pune. Thank you, Madam. And my sincere thanks to judges for paper and poster presentation, Professor Binu Jo Sir, Dr. Sudha Singh, Madam, Dr. Rahul Pandit Sir, and Mrs. Sweta, Madam. Thank you, Sir and Madam. I must mention our deep sense of appreciation to respected Dr. Su Narula Khanna, Madam, Founder, Patron, Nursing Scholar Society, Professor Binu Jo, President, Nursing Scholar Society, and Dr. Alka Tajni, Secretary, Nursing Scholar Society, for always being us for the guidance and the support. Thank you, Sir and Madam. We are grateful to Honorable Registrar MNC, Madam Rachel, for her constant and meticulous guidance for our CNE to get the credit points. Thank you, Madam. I extend my sincere gratitude to Director SHPR, Dr. Adarsh Lata, Madam, for her help for this CNE. Thank you, Madam. Here, we would like to put on record our appreciation for the continuous support extended by respected Vijay Rokade Sir, Assistant Professor, GMC, Nagpur. Thank you, sir. We thank all our wonderful participants who have turned up in such a irresistible enthusiasm, and without them, this conference is not possible. Thank you one and all from my bottom of heart. I offer my sincere thanks to our PG students for their hard work, sincere contribution to make this conference a great success. Thank you all. Lastly, all the members of the organizing committee and all teaching, non-teaching staff of Srimati Radhika Bai Medhe College of Nursing and School of Nursing who have been involved in this particular event. Once again, thank you all. Thank you very much. Participants are requested to just open video so we can take some snaps. Thank you once again to everyone. It is a kind request to the participants. Kindly fill the post-test feedback, and if you are facing to get problem, the certificate, then you can contact us or any of the organizing committee. Definitely we will help you. Thank you everyone. Thank you once again. Dear participants, the post-test and feedback is in a chat box. So you fill the post-test and chat box because we are going to end the meeting now within 2 minutes. You will get your certificates within a week.